Sir, and a very good afternoon to everyone. First of all, I would like to congratulate Dr. S.N. Sarraf sir and Abhishek to start this wonderful event of spine. And on behalf of Spine Society of Bihar and your trauma, I welcome all the delegates, all the national faculties, and all the local faculties who are going to deliver their talks. So when I go back, I see that we have formed Spine Society of Bihar, I think 6 or 7 years back. And it was the motive of the then President Dr. V.K. Sinha and myself as a secretary to do something in spine. So this has, the momentum has gained, and we have successfully conducted the national ASICON in 2022. And it was a very successful event. And from then, it has grown up so nicely that I am really proud of it, that now in Bihar itself, so many good spinal surgeons are there with all their amenities. I think Mahesh Kumar, Abhishek and Gautam and everyone, so they are doing exceedingly well with all the equipments, the latest equipments. I think the O-arm and the navigation, every facility they have in Sistu and it is growing on very nicely. And with this continuous effort, this has started the AOS Spine hospital-based seminar, and it is really a good move towards it. So once again, I congratulate all the members who are conducting this seminar, and I welcome all of you to this wonderful seminar. And I think we are a little late, so without wasting much of the time, it's better to start the program now. So our first speaker is Anand Shankar, who will be telling us about the examination of spine. Anand Shankar.
Thank you, Dr. Abhishek, for giving me this big opportunity here in front of you, in front of all the stalwarts of the spine. This is something very common, and you get everywhere in the book, examination of spine, especially the lumbar spine, because the theme is the lumbar spine. And there are two things. One is knowledge of the spine, another is understanding of the spine. By examination, you get some knowledge and you try to understand something that you want to accomplish. So I will be focusing on that. I won't be teaching you anything that is given in the book. So anatomy of the spine is really vital to knowing the spine, to understanding the spine, how it works and what it is actually. Is it a single bone? It's a group of bone, how it acts? Is it the whole spine acts from top to bottom at a single, or it's all the way different? So these are usually that what you see in the book, the history, that the very start of the examination, you starts with the history, inspection, palpation, percussion, auscultation is questionable, and movement, measurement, neurological status. These are the things that you have to do in the spine, and it usually starts when the patient enters in the room. So why you need examination? Is it really necessary? Or that current all the tests, there's a MRI, CT, is that enough only? So we examine so that we can give the patient an appropriate investigation. We can see the patient through a particular disease or particular symptoms or particular anything else that we are not missing. So we try not to miss any information by examination of the spine to make a clinical diagnosis and cut short the list of investigations so that the patient is not overburdened with the investigations, saving time and money for the patient. So that we can start the treatment very early, and we can decrease the morbidity and possibly mortality of the patient also. So when to examine spine? So only the spinal pathology, trauma, Is it we need to examine the spine, or in any other things we need to examine? Is there any systemic disease that involves the spine? So we need to examine the spine at that time also. Any syndromic cases that is involving this, that may involve the spine, we have to need to examine the spine to see the spine. Anesthetic point of view, do we need to examine the spine? Anybody can tell? In anesthetic point of view, what is important for in the spine? So they are giving spinal anesthesia. In elderly, they are having very difficulty in giving spinal anesthesia when you are treating any intertrochanteric fracture or in the lower limbs. So you try to get an X-ray so that we can plan and manage accordingly. And that may be associated with CNS pathology and trauma. So how to start? We have already done that. So we have to keep in mind what or at what age group we are seeing. And is the patient is newborn? So we have to keep already in that mind. So in newborn, what we have to see, what is the pathology is there, and what other things we have to see. Is he a child? Similarly, adolescents, adult, or an elderly. So the seeing the spine, examination of the spine each and every time changes. Each and every age group it is changing, and it may be common with the some age groups. So we have to see congenital, syndromic part, traumatic part, deformity part, degenerative part, any tumor, osteoporosis, local, systemic. Is there any accommodating arthritis, infection is there, or any other thing that I am missing? You can add on to that. So what and how do we need to examine? So while examination of the spine, do we need to examine only the spine or something else? Or it is spine and paraspinal muscles? No, we have to examine a lot of things while examining the spine, because whenever we are planning to something to do on the OT table, we have to check the patient top to bottom, not only the spine. Whether if we are planning on a spine, so that anesthesia is usually general anesthesia. You have to intubate the patient, so you have to check the oral cavity too. So you have to plan accordingly. You have to convey the anesthetist your whatever examination you have got. You have to examine the neck rigidity and neck stiffness. You have to see the shoulders, the thorax, abdomen, pelvis, limbs, and most importantly neurology. In neurology, you have to see not only the upper limb and lower limb, but also the bowel and bladder involvement and other things. So how do we examine? Can we examine the patient in sitting, or standing, or supine, prone, in lateral position, or in mother's lap? So we have to judge the examination accordingly. So what do we need to observe and note accordingly? So is there any anatomical changes like scoliosis, kyphosis? Is there any congenital deformity or any listhesis, something like that we can see, we can feel, we can palpate. Counting of the vertebra, another important part. Skin, we can see the tuft of hair. Mobility, each part of the spine, cervical, it is moving accordingly or not according to the age. The thoracic spine, the lumbar spine, is it moving or not? The power of the upper limb, power of the lower limb, which group muscle of the involvement is there, and which root is involved, what level of the spine that is being involved. Is there any swelling in the spine, around the spine, in the iliac fossa or in the paraspinal regions? So what does it interpretates? So you have to see accordingly. Mouth opening, as already I have said, and stiffness of the cervical spine. So we have to need and observe and note accordingly so that we can completely treat a patient. We are not treating a spine, we are treating a patient. So this is a neurological chart. Is it complete or incomplete? So never it is incomplete or never it is complete. You have to give your inputs, you have to make the note so that you can examine the neurological examination over and over. The different charts are available, and this is on the back side of the same chart, and you can give the information, you can note the information for the further use. So any other examination after this is left is CNS examination. Is it necessary in examination of the spine? Maybe, sometimes. Recently in the IGMS I have been confronted with that neurosurgeons. They said something like CNS paraplegia, something like that. I don't know what is that. I didn't get anywhere. But they said like there is CNS paraplegia. So how to differentiate the between paraplegia from the brain and paraplegia from the spine? Or quadriplegia and quadriplegia, same thing like eye examination. If it is there is ankylosing spondylitis or you have something, any systemic disease, you may refer to the patient to the eye examination, cardiology consultation, physician consultation. For the chest expansion and heart consultations, everything. Rheumatology consultation you may need. And you may need to examine the other systems also. Bowel bladder examination, whether it is functioning good or well, what is that there. So what next? Is it complete? You are a better judge. Complete appropriate treatment of the patient starts by examination. Investigation, don't jump directly to MRI, go ladder by ladder. PAC and operation. Is it complete now, examination? No. Another examination is post-op examination. You have to examine the patient post-operatively so that to reduce and detect the complications early. And post-op, family recovery charting by the examination. Does it end now? I think so. Thank you.
Hello. Now I would like to invite Dr. Guru Raj, who will be speaking on AO spine course in some time.
On behalf of AO Spine, I am the education officer for AO SIN, India subcontinent. And on the behalf of AO Spine, I would like to welcome you all and thank Dr. Saraf and Dr. Saraf both for organizing this wonderful meeting here. The main idea behind organizing this hospital-based seminar is to educate our residents and junior doctors into the basics of spine. And so we would like to keep this more interactive. So let's have a more interactive discussions rather than having a didactic lectures. So whenever you have questions, we can dedicate more time for questions and clearing your doubts and making you maybe a little bit better in your spine knowledge. So I welcome you all, and then let's have a good session. Thank you.
So let's have a big round of applause for our national faculties. We are very pleased to invite Dr. S.K. Srivastav sir, who is currently President of Association of Spine Surgeons of India also. AOSIN chair course person Dr. Guru Raj sir is here, Dr. Ayush sir is there, and like lot of local faculties are also there. Now next talk is on radiology of MRI, or how to read MRI of spine, and Dr. Anand Sankar will be speaking on it.
Thank you again, Dr. Abhishek. Dr. Prabhat Ragwal sir yesterday told me to present his lecture. So I am not good at this, but I can put something, and I try to read his slides, and I will try to replicate something to you. So how to read an MRI of a spine? So when do we start reading an MRI? Again, I will go back to the basic first. So what we need or what we reading in the spine, we have already done in examination of the spine. So what we examine, we try to find out in that thing in the MRI. So if something that we have, what we are getting nowadays is that our junior doctors or something, I see that the patient, some spine of the patient of the spine comes, he said, oh, give me your X-ray and MRI. He doesn't goes and take pain to see the patient and do like that. So if somebody is doing like that, I throw him out of my OPD. But so this has become very readily, they don't have time to examine the spine. So how they will find something that he don't know in his mind, so how will see in MRI, I don't know. So the objective is to basic learning the sequence of MRI to identify the different anatomical structures on the MRI. So the anatomy is again very, very important in this. If you are reading any X-ray, MRI, whatever it is, to classify the disc prolapse on MRI, to identify potential signs of lumbar spine instability, to evaluate MRI based different surgical approaches on the lumbar spine. So these are the various sequences that we get: T1, T2, STIR, that is fat suppression images, contrast, gradient echo, and proton density images. So this is a chart that shows what tissue will be seen how. So it's difficult to write what we can see, but it is something has been written in that table. So this is a T1 sagittal image. As you can see, the fluid in this is dark, and in T2 that will be, as you can see the spinal fluid, you can see it clearly. So these are the basic differences between T1 and T2. These are the few MRI pictures, that is GD-DTPA enhanced T1 sagittal images of the lumbar spine. A pathological burst fracture is there at the level of L4 vertebra. That is evident with this patient along with myeloma. Note the low signal edema on tumor or both within the fractured vertebra and other neoplastic foci at the T12 and L3 levels also. And in the same spine, after having the STR image, we get a new image in a new picture in S1 vertebra as well. So this is the importance of what do you want to see and what else you want to get, so that you can get the correct diagnosis. So these are the anatomical structure, and what do you want to see is the yellow line, the big yellow line, that is demarcating the posterior border of that vertebral body. It is demarcated with that violet line, the dural foramen, that traversing nerve roots are there, the lamina is there, spinous process, pars. It's a picture to show the anatomy of the spine, what you see in the different cuts. Another picture that show in the sagittal image what you need to see: the superior end plate, inferior end plate, the number of the counting of the vertebra, the conus medullaris, the CSF fluid, and all other things. The anterior longitudinal ligament, posterior longitudinal ligaments, the bulge, the disc is there or not. So how does a normal disc look like? So in this sagittal picture, you can see that all that that's a pointer. So as you can see, this the posterior longitudinal ligament is here and here. It is almost straight. So there is no disc bulge. This is normal. The discs are all normal. In this is also there's a bean shaped there. This is the neural canal, and so all normal anatomy. This is these two images that see, these are the almost normal disc, and these discs are black. These are degenerated and dehydrated discs. So in this picture, here it has been denoted as the annular tear. The disc has been protruding out from here, and this is the another view that we can show here, and here it is protruding out a little bit. So this is a graphical, this is a representation showing the various discs, what you can get. This is diffuse disc bulge, broad based protrusion is there, local disc, and disc extrusions are there. Sequestration is also there. In this picture you can see the sequestrated disc. So this is the picture showing the diffuse disc bulge. It's not very much prominent. This is the focal disc bulge, here we can see here, and here also. This is disc extrusion. This is a large disc coming into the neural canal, and it has violated this posterior longitudinal ligament. In this picture also you can see that size of the disc, and this it has already, the posterior longitudinal ligament is gone. This is sequestrated disc. This is the level, or this might be the level. The disc is here. Most probably the disc is the level and the disc is there. Similarly here you can find the disc is not in the line with the disc. So this is called sequestrated disc. So this is the picture to represent the which part of the disc is gone and what is it called. The central, paracentral. This is for foraminal, and this is extraforaminal. And the rest of this is anterior. So I haven't seen any anterior till now. So this is another MRI picture that is showing vacuum vertebra body and calcified disc. So this is that pathology. This is the vertebra pathology, and there is some space here, and this space is caused by nitrogen in a vacuum vertebra. It is seen, and here we see that calcified disc here. So it is a what we get in that MRI plate is very small. So in most of the institutions or most of the time. So if you get a disk or you get a soft copy of the MRI, you can get a enlarged view in your desktop and you can see very easily on these things, but you can very easily miss on that MRI plates. So this is the another image to show that diffuse disc bulge has the multiple levels. This is, you can see that the diffuse disc bulge has the multiple levels. This is central canal stenosis. As you can get easily evident here, the canal is almost obliterated. This is only the part of small canal is remained. So this is lateral recess, and this is foraminal stenosis. As it has already been narrowed in each and every level. There is a huge disc here also in the lateral part. This is the neural fragmentum, how to nerve really gets out. So each and every, there is a various sections are there. So 2-3 sections are there, and this is that another view to show how the roots are exiting and from where it is exiting. These are the few of the recurrent disc postoperative. This is spondylodiscitis infection in the different T1 image, STIR image, and T1 contrast enhanced. So the same patient with different types of pictures. And this is another picture showing pathology, abscess, most probably tuberculosis. And this is the same patient. You can see how extensive that abscess is. So you can miss this, ectopic kidney. So if you don't know the anatomy, what we want to see, if you want to see just a spine, you want to see any other structures. So if your screw pass, you entered which structure you won't know, and whom to call you won't know. So you have to know all these things while reading an MRI also. And this is just the evaluation of the lumbar instability. I won't take much time. Thank you.
Thank you, Dr. Anand. I will be taking questions after 2-3 more presentations. I'd like to invite Professor Dr. S.K. Srivastav, sir. He is the president of ASSI. Sir is at KJ Swamya Medical College as professor. He has been past ex-professor of KEM as well at Mumbai. So we are going to learn a lot from you, hear a lot of wisdom. So please, sir. Thank you.
Thank you very much. A very good afternoon to all of you. I sincerely thank AO Education Committee, local organizers, specifically Dr. Saraf and his very brilliant son Abhishek Saraf, and the whole spine group which is present here. It is my proud privilege to be there in my birth land, and that is Bihar. I am quite happy that a lot of PG students are there, but I will request you must interact. And what Dr. Guru told, the purpose of reaching to each and every part of the country is to spread knowledge. So you should not hesitate. The topic which has been given to me by Abhishek, it is a large topic. I think in sequence there are 4 lectures. So what I have done, I have combined each one and made a general. If you see, all these pathologies are from the degenerative spine. You see disc prolapse or lumbar canal disease. So I have combined everything, and then I will be going slowly to explain that. So clinical assessment, imaging and management strategy in lumbar disc prolapse and lumbar canal stenosis. Lumbar disc prolapse and lumbar canal stenosis are common degenerative pathology where patient becomes symptomatic and may present with cascade of events, and there is a representation clinically also. In your practice also, the maximum patient you will get initially is all these degenerative spine cases. Patient will come with the back pain, and back pain is a big thing. You have to search what is the pain generator. So the commonest thing which you see is acute low back pain, and this is usually due to disc prolapse. Sometimes it may be acute on chronic. There may be radiating leg pain, tingling numbness in lower limb, and motor weakness in lower limb. And usually patient comes with the sciatic list. He is bent forward and movement becomes difficult on the very first day when he has this episode. In other, after following this cascade, and as the person starts going towards higher age group, The canal stenosis is a common thing, and where he presents with the stiffness of the back, chronic back pain, neurogenic claudication, stoop posture, motor weakness in lower limb in severe stenosis. So usually you don't get motor weakness in the initial phase of it, but later on it leads to ischemia of the nerve and direct mechanical compression leading to deficit. So this is the cascade. Each one of you must know it. This is known as Kirkcaldy-Willis concept. So first there is an internal change in the disc, then there is a disc herniation, intervertebral space reduction, so there is a crowding of the space, the overloading of the facet joint, and there is a ligamentous laxity. It leads to instability, degenerative spondylolisthesis, and patient has frank spinal stenosis. It can lead to adult spinal deformity. The thing starts at one zone of the column. If you think the segment of the spine is a tripod, anteriorly there is a vertebral body and discal joint, and posteriorly there are two pods. These are the two facet joints posteriorly, and the things are starting, and that's it affects the column. And this is the thing which was described by Kirkcaldy-Willis. There is a stage of dysfunction, then instability, and body tries to stabilize it, and there is a stage of stabilization. Now there are genetic factors, aging is one of the factors, poor nutrition is another factor, and there are environmental factors. So if you see the degenerative changes, it starts from top to bottom. Everywhere you will find the different stages of degeneration. At one place there is a dehydration of the disc, another place you will find there is a little prolapse, third place you will find there is a canal stenosis, and in some lower down you might find some instability. There is a minor degenerative slip. So then, and there is a combination of all these things happening in the different part of the column. The degenerative spine is a Pandora box. There are normal expected physiological aging changes, more so in elderly age group. Remember, all elderly persons are not patients. So they come with the finding, and they may be just a radiological finding. All degenerative changes are not symptomatic. We must understand. Pick up the pathology causing symptoms and signs, and you have to be very methodical. Now, why this is happening? If you see any articulated structure, any machinery, the more number of joints, the more chances of wear and tear at multiple places. I have just given this example. It requires regular maintenance. For our spinal column also, it needs to be maintained by care of posture, muscle strengthening exercises, essential supplements for bony, neural, and other soft tissue health. So this is actually cause why this multiple area, multiple zone spine is getting degenerated. So degenerative spine is the commonest cause of the back and leg symptom. And you in OPD you have loads of patients, but you must stick to the protocol. Now this is the today's scenario. You get a X-ray MRI picture in WhatsApp. So this is known as WhatsApp consultation. And you tell the person, surgeon in my area has advised surgery and need your valuable opinion. So you start seeing this, you are sitting in your chamber or maybe at home, and you see 3-level compression, many bulges, more at L4-5, and then you think I will do 4-level pedicular screw fixation, 3-level decompression, maybe at L4-5 I will consider PLIF, rest places I will put posterolateral fusion. So you have already planned your treatment, and this is known as image treating surgeon. Remember, 65 years old patient's MRI would have radiological changes definitely. And why should it would be like 35 years? It is age related. That may not be a symptom generator. So this is never examine the patient without taking history, and never see images without examining the patient. This I will more stress for all younger generation. This is extremely important. In degenerative spine, good history taking will give you 40% information. So thorough clinical examination, additional 30%. You only require 30% for investigation. So this is extremely important. You listen the symptom and start visualizing the pathology. If it tells on the left side I am having pain in the gluteal area, or it is going radiating to the leg, outer part of the leg, it's supplied by L5 nerve root. So you start imagining where is the compression. That should be, the nice taking history, so that you come to that conclusion. Conform with the clinical findings, reconfirm with the radiological finding, follow the specific treatment protocol. You see here, there are so many things are visible. Okay, pain generators are visible here. There is a disc prolapse on one side. There is a facetal orthopedic. See, bilateral, both the facets are full. So these patients, they might be having instability. So all these things has to be visualized while taking the history. Now we are going to stick to now lumbar disc prolapse. Okay, so a herniated or ruptured disc is a common condition where the nucleus pulsosus bulges, protrudes, or comes out through the weak point of annulus fibrosus, leading to back pain or radiating pain to the limb. And you can see here the posterior part, posterolateral part, where the annulus is very weak, that is the site for coming out this disc, and you can get a classical radiation to the lower limb. What are the predisposing factors? Gender, improper lifting, heavy weight person, sedentary life, repeated action, torsional stress, driving, and smoking actually leads to poor health of the spinal column. Now there are different words which are used. Normal disc bulge is a normal turgor pressure, because it is like a balloon. So there is a little bulge on the side. This protrusion, herniated portion of the disc may be covered still with the thin annulus. When you say extrusion, it has come out through that thin annulus, but it remains continuous with the disc. See, this is the difference between disc extrusion and disc sequestration. Sequestration, it doesn't have any connection with the parent disc. So that's how we would differentiate. Okay. So whatever the mobile area of the spinal column is there, the chances of disc protrusion are high, or wear and tear is high, like cervical spine and lumbar spine. In lumbar spine, L4, 5, and in cervical spine 5, 6 and 6, 7 are more common. Thoracic spine is not common because it is less mobile. Okay. The most common cause is sudden violent trauma, less violent trauma in degraded annulus. Okay, there may be lifting, bending, coughing, and sneezing indicate leads to problem. And there is a classical clinical feature you find: patient is tilted to one side, bent forward. There is a radiation of pain to lower limb, tilt in the back and it is known as list. So there is no rotation; they are just tilted to one side. There may be sensory symptom in the form of tingling, numbness, burning pain. Neurological deficit may be there, and commonly it is in the ankle and foot. So that is the side, and in some cases you can have cauda equina syndrome, and there is an involvement of the bladder bowel. Clinical finding, you will find sciatic list, there will be muscle spasm, it will be tender, straight leg raising test will be positive, coughing increases the pain, neurological deficit according to the specific nerve root involvement, there may be hyposthesia or paresthesia. Now this is the sensory dermatome, and this will guide you where is the lesion. That is extremely important. And they are the provocative tests. Now this is for the postgraduate who are going to appear in exam. All these tests, actually it tells about the tension sign of that nerve, and you should be knowing about it. Now remember, whenever we do this SLR, this is a passive test. Active test for anyone? Active SLR test is done for what? Patient, you ask the patient to lift. It is for SI joint. It is not for nerve root sign. Okay. So that mistake should not be done in exam. Okay. And well leg raise test, when patient is complaining of pain on the right side, but when you lift the left side, this is known as well leg raise test. And it is positive when there is a very large disc or there is a axillary disc. Okay, so patient is complaining on right side, but when you are lifting left side, then also it is painful. That gives hint where that disc is lying. And there is a reinforcement test. You slightly lower the whole lower limb and try to dorsiflex the ankle. So you have accentuated that tension. Okay. So 0 to 30 degree is for the laxness. Laxness disappears. After 30, like 40 to 60, your patient will have severe pain or reproduction of the string. This is bowstring. Again, you reinforce. You lower the limb and you press on the knee. posterior popliteal fossa and patient will have pain. Slump test is practical, it is very useful, you must do it in OPD. OPD in each and every patient you will not be able to make him lie down in sitting. So this is SLR in sitting position, okay, like that. See, now you flex the knee and try to extend the knee and flex the cervical spine. Now here how to accentuate, you ask now to dorsiflex the ankle, see how this. So this is practically like doing SLR in sitting position, slump test, okay. Reverse for the higher roots, if you have femoral nerve involvement, this test will be positive, okay. And you should be aware about the dermatome, each nerve root supplying which there are overlap of nerve roots also for one area. So classically we say this, you must remember this. So go down like this, L1, L2 iliopsoas, 3 is for knee, 4 is for ankle, 5 is for EHL, S1 for plant. Okay, very simple for all postgraduates. Now you never forget to palpate dorsalis pedis and must see Homan sign. Dorsalis pedis tell you the arterial situation, because some of these patients are elderly, they might have peripheral vascular disease, and SI joint and hip joint has to be examined. Investigation in acute disc prolapse, there is a loss of lumbar lordosis. Chronic, you have reduction in the disc space. This is the only finding. Actually, this was shown just now. But what is important for spine, you have pointer, you can actually plan your surgery. Now see, this is the exiting route and this is the traversing route. At L4-5 disc, which is the traversing route, it is the L5 route, which will come below the L5 pedicle, But here at this level, this is already exited. Proximally it gets exited, L4, okay. So here is the site for exiting route and this is the site for traversing route. And whatever you bundle of routes you are seeing, this is also known as in canal stenosis, that is carotid is disrupted, you are not visible. Okay? It settles down because MRI is being taken in supine position. So all these nerve rootlets, it gets settled down in this bottom area. And this is the one thing which will not be there when their patient has significant lumbar canal stenosis. Got it? Now here classical disc prolapse, you can see this shadow, hyperintense shadow. You see the width of the nerve root here and width of the nerve root here. So it is definitely affected. And these are the different types. So this is the central disc, this is central disc, this is paracentral by the side, and here it is far lateral disc. You can sometimes see in the foramen also, disc sequestrated. Now see here, now this piece is separate. You are seeing this intensity. Sometimes you open and you find the disc is lying over the dura. It migrates up, sequestrated disc. And this is just for theory exam, because sometimes this is asked deformation, spinal, how do you grade it, minimal, moderate, severe. Remember 2 and lower down for vertebral canal 7. These are the two figures you remember. And usually it is not commonly asked, but sometimes it may be asked in theory. Now this you must know, Firman grading of disc degeneration in MRI. So there are 5 grades, and as the degeneration continues, this now it's well hydrated disc, then there is a fragmentation started, then this color goes now and then changes on the vertebral end plate. Okay, and all these things start reading on each and every patient's MRI. Modic changes in the bone, vertebral body, there are modic changes. And sometimes this is wrongly put AKT on this patient. You think this is tuberculosis, which is not. This is a blunder. Okay. Now this is very important for the recurrent disc, and distinguish between post-surgical fibrosis and recurrent disc herniation. Because after surgery there will be fibrosis, and that should not be taken as if there is a remnant disc or sometime it has come again. Okay, I treat always all these patients conservatively. You should also try to treat many of them. 95% disc prolapse, it gets treated nicely with conservative line of treatment. Okay, analgesis, anti-inflammatory, muscle relaxant. Nowadays also I give traction, pelvic traction. I don't feel bad that I am still giving traction, and it does improve. I have a record to show you. Okay, I have a severe cervical disc prolapse. My elbow extensor was grade 3. Today it is grade 5. Extended conservative treatment. Now, you just, what is the problem with the patient? He is having severe radicular symptom. He doesn't have any neurology. Just give relief, give the medication there, and patient becomes all right. So this is extended conservative treatment. When you now plan surgical treatment, progressive neurological deficit, persistent disabling pain lasting more than 6 weeks that have failed non-operative treatment, and cauda equina syndrome. What are the poor prognostic signs? Now patient has come to you already, he has wasted so much time, 3 months, patient with disability lasting for more than a year, smoking, obesity, he is not going to do well. And if it is, disabled, I think you must intervene and do the needful. The surgeon and patient must realize that this surgery is not a cure, but provides symptomatic relief. It neither stops the pathological process nor restores to normal state. This is extremely important. Positive predictors for good outcome of surgery, leg pain being chief complaint, not the back pain, leg pain. Positive straight leg raise test, and weakness that correlates with the nerve root impingement. Sometimes you see multiple area disc protrusion. Which one is causing problem, it is very important to know, and that area should be tackled surgically, and this you can know with the root blocks. Okay, this is the one way of knowing which is the pain generator. The surgical, you can do open discectomy, micro discectomy, or endoscopic. Okay, so basically you reach through this proximal. So here you will find that if suppose I tell you, you put a probe, where will you get the disc? This is the site you will get the disc. There is the inferior arch of this lamina here. Okay, then you here just to see, so you when you operate, be parallel to the nerve root. When you expose the spine, you go from below upward. When you tackle this nerve root, you go from up down. This is the principle of spine surgery. Okay, so you can do laminectomy, but nowadays nobody does it. You do interlaminar, and now see. Now directly you will end up here. Endoscopic discectomy, UV, and just inferior to that, interlaminar, transforaminal, tubular discectomy, micro discectomy, then laminotomy, or do fenestration, then interlaminar or hemilaminectomy, and this is disliked by everyone, laminectomy. But what should be your training? It should be this way. You should be able to treat your complication. Remember. So if you have already done few, not I'm telling you, you spend your 5 years, it is not required. You spend some time to know the open procedure. So whenever you are trapped, you can open it. There is no harm in that. Okay. All these open procedure patient has been doing very well. Only you want to reduce the surgical trauma to the soft tissue, which is not required. So that is fair enough. Complication of lumbar disc. What are the complications? This can happen to any surgery: wound infection, post-operative discitis. There may be dural injury, nerve root injury, cauda equina syndrome, pulmonary embolism, thrombophlebitis, and injury to abdominal viscera and vessel. He rightly told, there are incidences, the cage has been put and cage has gone into inferior vena cava and reached to pulmonary vessel. This is reported. You can injure the abdominal aorta. So if you are not careful. Now what are the indications for fusion? Marked segmental instability. If the unstable, you must treat. And all these instability cases has given bad name to spine surgery. If you have not identified instability, you have just done the discectomy, he is going to remain in bed for further 3 months. Now, what are the disadvantages of fusion? Alter spine biomechanics, causes degenerative change in adjacent spinal motion segment. We say it is adjacent disease. Now, this is the another thing. So, if you go through the indication and contraindication, you have at least 13 contraindication and 2 indications. So, choose your indication and then you can do it. Scientifically, long-term functional, now I will be telling you something about the literature on which you can stand and tell loudly. Long-term functional outcomes same, irrespective of different procedure, and this is article, and this is not old one. You can see 2022. Okay, given the higher reoperative risk with microendoscopic discectomy compared with microendoscopic discectomy compared with the microdiscectomy or open discectomy at a median of 4 years follow-up, surgeons should select microdiscectomy or open discectomy despite the current popularity of this. But you choose the thing. I am not going against this procedure, because this is quite beneficial, but be master in that and start doing it. Okay, there is a moderate quality evidence suggesting no difference in leg pain or functional status of intermediate and long-term follow-up between PTED or OM in treatment of disc prolapse. Again, similar thing. So see, because it has stood test of the time. Okay, discectomy, open discectomy. So this is going to show the good result. It doesn't mean the other is bad, but you have to train yourself. Okay, open discectomy versus micro discectomy. Result from 519 patients. Okay, we believe that both methods can be safely used under appropriate condition and surgical experience. This is important. Now, canal stenosis. Now this is the sister of disc prolapse, called lumbar canal stenosis. Okay, lumbar canal, it is a progressive degenerative process, narrowing of the central spinal canal, lateralis, and other neural phenomena leading to mechanical compression of the neural tissue, symptoms of neurogenic claudication, pain, paresthesia, weakness, and reflex. You see MRI myeloplate, nothing is visible there. It is totally compromised. It may be congenital, acquired congenital, they have beginning. Sometimes you get a patient where young patient and a small bulge and patient has severe pain, and the moment you put attention to his canal, is a congenitally narrow canal, and that has led to that problem. Okay, metabolic disease like Paget's disease, fluorosis, already they have compromised canal, stenosis due to spondylolisthesis. What is the clinical presentation? Usually middle age or elderly patient, they have neurogenic claudication, and gradually this duration decreases. Unilateral or bilateral symptom, maybe there may be back pain, because they are not isolated just compression, they have facetal orthopathy, and facetal orthopathy is really bad. It is like your knee joint pain. You try to remember that, and that's how they walk, they sit for some time again, or they just stoop forward and their symptoms get relieved, and that the posture they take. There may be numbness, heaviness, losing grip over chappals after some time of walk, and there may be some weakness. Always examine upper limb, because there may be tendon stenosis, and so I know cases patients have been referred to me, lumbar spine surgery he had not taken because screening was never done earlier. So he had upper motor neuron signs. He thought of the lumbar disc surgery. He put the patient prone. When patient got up, he was quadriplegic, because you missed the clinical examination. Otherwise, you have definitely got the spasticity, some exaggerated reflexes. Beware of the SI joint and hip joint pathology. These are the bad thing, and sometimes the result is not good. Patient who is having long standing diabetes, patient of Parkinsonism, the surgical outcome is not that good. Okay, symptoms pertaining to vascular claudication. This is the chart you must memorize. How will you clinically differentiate whether it is a neurogenic claudication or vascular claudication? This is important, you must know it. At least put your hand on the dorsalis pedis. Take the blessing of the patient. Put the hand on the dorsalis pedis. Clinical application, all these things are there, and this lead to all this. See, arthrosis is stiff, it leads to stiff back, stenosis, root impingement, low back pain, and radicular pain. Instability, again will have significant back pain. So this is the degenerative spinal stenosis. You can see lower down, both the side space is significantly occluded. This is the joint where there is a synovial fluid. And see, even the direction of the facet joint actually changes. One you will find vertical, another you will find trans, like this. Okay, and there are torsion also. And there are different types: central and peripheral part, foraminal stenosis. These are the least zone. This you must know. The central area, then in lateral part you have entry zone, mid zone, and exit zone. And these are the examples. Okay, you should know this. Here also you can see the facet joint is full. Okay, so there are the three zone, and when you identify pre-operatively, you make effort to decompress that area, because there is the stenosis. This I will just skip. So this see, if you try to just know what type of patient this would be, he is having back pain. Usually herniation it occurs below 50 and this is more than 50. Tension sign, neurological findings will be there in the disc prolapse, which will be initially it is absent in there. So all these things are important to know that. Now investigations you know. So when you suspect instability, you must ask for flexion extension view. See here. Okay, so you will have instability and you will have to pay. Now this is the question nowadays we ask, what is Jones index? Because you have forgotten to read the X-ray, you directly see the MRI. So you get enough information by this Jones index. Okay, nowadays it is not given in books also. So you mention the dimension of this canal as well as the body, and this ratio should be 1:2 to 1.4.5, 1:4.5. This direct APN canal less than 10 millimeter is absolute stenosis. You can have myelography, now nobody does that, but earlier we used to do this myelography. There used to be filling defect of the dural sieve, filling defect on the extension of redundant root and root cutoff. Okay, it is invasive, so nowadays it is not being done. You have MRI, and this is the gold standard now. Okay, you can see each and every change there, and here I was telling you this. Everything is clumped here, that settled sign is not there, and dural sac area, that is known as DSA, if it is less than 110 millimeter square, it is definitely the canal stenosis, and the sedimentation sign is positive. Method you are not able to visualize those things properly as compared to the normal. CT scan, bony stenosis you will be able to identify. So mid sagittal diameter, if it is 10 millimeter less than 10 millimeter, definitely stenosis. If MRI is contraindicated, you have put the steel implant in the spine, then CT myelo can be done, and you can see that's how you get the compression at multiple places. CT myelo is. This is the test which is many people they are not able to know what is the actually reading about this, what finding I should correlate with that. The nerve commendation, electromyography is important because sometimes you get confused with the motor neuron disease. So wherever you have a doubt, you should do. Okay, treatment plan. So whenever there is a stenosis, there is a compression, and you will have to decompress. Conservative treatment must be tried. Delay in surgical treatment does not change the outcome. Remember. So if you are delaying, it is not going to harm the patient. Select the cases severe, moderate, and mild. This is the conservative treatment. Do exercises. Sometimes epidural steroid does work, and treat the osteoporosis. Okay. So you have to identify the place, and you can inject that steroid, and it sometimes it relieves the symptom. It is an ancillary treatment by the brace and all. Basically, you should not give a normal lordotic brace. Otherwise, he will have more pain. So that is to be avoided. Flexion issue you can do. Now this is again literature. Observation seems to be an important alternative to surgical treatment, and severe progression was unlikely. So for this long time study, 41% improve, 41% remain unchanged. This I am talking about the conservative treatment, and 18% only worsened. So if you are doing regular follow-up, you will catch hold of these 18%. Okay, and this is another thing. The treatment result of delayed surgery was essentially similar. You must identify your patient. Indication of surgery: intractable neurogenic claudication, failure of conservative treatment. Okay, predominant low back pain is not reliably alleviated with the surgical decompression. Okay, so leg pains, if it is there, it will definitely improve. Isolated back pain is not a strong indication for surgery. Okay, and it is definitely elective procedure. If the patient comes with neurological deficit or deterioration, you must intervene early. Okay, surgical. Again, I am going to skip it because all these are literature. I think by now you know. Extent of surgery, unilateral or bilateral decompression, number of level and need for future. This you must know prior hand, what you are going to do. Once you open, what are the things you have planned, and that is the proper identification of the location of stenosis is extremely important. If there is a instability, treat it, pay attention to that. The goals are pain relief, increased mobility, prevention of neurological deficits, and key to successful surgery is complete decompression of involved neural element. Key to prevent late failure is preserve spinal. If you are doing open surgery and you are doing decompression, don't destabilize the spine. Otherwise, if you have done it by mistake or it is cut, it is unstable, then don't hesitate in fixing it. Avoid iatrogenic instability. Surgical technique again. Now this classification is important, and this was a very nice and landmark article by this Hansara. He has divided into two: simple or typical spinal stenosis and complex, and you must identify that. You see this side, less than grade 1, less than 20-degree degenerative scoliosis, you need not fix it, you can just decompress. But on right side, if you miss this right side, these criteria, and you don't stabilize the spine, there will be problem. Okay, so this classification is extremely important. Okay, decompressive surgery is suggested to improve the outcome in patient with moderate to severe symptoms of lumbar canal stenosis, and all these procedures have been tried in past. And if you choose your procedure properly, there will not be any problem. Just I will take how much time? Yeah, 3 minutes more. So now this is the procedure which is the diagrammatic view. You can do interlaminar decompression, you can do facet side, one side. So if you take out facet, 50% of facet, it doesn't cause any instability. Lateral, each zone you identify and try to decompress it. And this is the same chart by the Hansraj, result of laminectomy. This I will be skipping. I will be directly going to the case. And this now, this is out of market now. Nobody puts this interspinous spacer or decompress. And this is still some places it is used, the flexible stabilization. Now this patient, stenosis with instability, and you should know about these poor indicators, and you be careful. Reoperation, re-stenosis can happen, and adjacent stenosis can happen, and there again you have to go and decompress. These are minimal invasive technique are there. Microscopic decompression, Dr. Ayush is going to tell you in detail, and they stand you. This is the tubular retractor system, percutaneous endoscopy. Now this case I had, where this operated 7 months back with a minimal invasive technique. And this was the picture, and he developed deficit, and we have to revise, extend the feasible. Higher up now, it was somehow, it should have been addressed that time only. Okay, 4 months back had back pain and radicular pain in right lower limb, was operated 4 months back, endoscopy, discectomy, repeat procedure was done twice actually, history of intake of antibiotics, and see this picture, total block, he had deficit. And now you see the plain X-ray, there is a scoliotic tilt, and basically he came with the discitis. And this was the picture, and this was the contrast, and I did open, there was a pus there, and took out and packed the bone graft. Whenever there is a pyogenic infection, I usually avoid putting cage. And this is another case where it was a stable spine. You can see decompression was done. Decompression at this, and he improved. No need of any fixation this. So we have done even long decompression also. Chronic back pain, significant radicular symptom, and instability. You can say frank instability. Decompress it. Don't compromise on decompression. This is extremely important. Okay. And this is another patient. Dynamic view. There is a frank instability. So you must fix and fuse. Now that was marked there. Confirm the level. And lateral gutter was extremely tight, and we have done it. And so I'll conclude: appropriate patient selection, in identification of the cause of the symptom, judicious surgical planning for neural decompression gives best outcome in degenerative lumbar spine. If anyone wants to ask, specifically postgraduate, they are most welcome. I am here only till the end of this session, so you can ask me question anytime.
Thank you so much, Dr. Srivastav sir, for your expertise and insightful presentation on lumbar disc prolapse as well as lumbar canal stenosis. I take this opportunity to thank you, sir, that you agreed to come and share your knowledge with us. Your contribution to the success of this seminar is greatly appreciated. I also invite Dr. Upendra Prasad sir, President Bihar Orthopedics Association, to present a memento, a token of respect to Dr. Srivastav sir, who is President of Association of Spine Surgeons of India.
Thank you.
At the same time, I request all the audience, all the PGs, that if you have any kind of question, you can ask sir. I already have a question, sir. After this presentation, I will ask. Sir, sir, I wanted to ask that, like in your presentation, you like repeatedly told that decompression is very much necessary, like proper decompression. Nowadays, in era of OLIF, most of people do indirect decompression. They don't decompress directly; they do indirect decompression. What's your take on that, sir?
Actually, now also they don't ignore it. See, earlier when it started, Olif, in fact, they did it from, front, and then they again watched the patient, because there it is a indirect technique of decompressing. We know with this pathogenesis, there is a collapse of the column. When there is a collapse of the column, there is a buckling of ligamentum flavum. Okay? When you distract it, it automatically with the ligamentotaxis, it opens up the space. It opens up the neural foramen. So they reassess after surgery, patient is able to walk him. Then always there is a next chance to do posterior.
All right,
So they are not compromise the decompressing the space. They are lifting the column, they are opening the column, so the space is reorganized. Okay? If there is a persistent symptom, they go behind and they decompress it. I have seen some of them doing it.
All right, sir. All right, sir. Thank you so much, sir. Now, I invite, it's my pleasure to invite Dr. Nisar Ansari, a very good friend and a very good spine surgeon, to share his insights in understanding degenerative spondylolisthesis.
Hello, respected seniors and dear colleagues, and Dr. Nisar, and I will be speaking broadly on this topic called as degenerative spondylolisthesis. Basically, what is degenerative lumbar spondylolisthesis? In degenerative listhesis, what happens that one of the vertebra slips on the vertebra below, and there is with an intact postural neural arch, and it's very common. Not very common, it's common in the elderly, especially women, and the most commonly the affected levels are L4-5 and L5-S1. Now, why is this level affected more than the other? It's because of the increased shearing stress in the lower part of the spine, mostly L4-5 and 5-S1. But no, L4-5 is more commonly affected than L5-S1 because the L4-5, the facets are more sagittally oriented, and so L4-5 is most commonly affected. The clinical presentation, the symptoms, they can be mechanical or it can be stenotic. Mechanical, mostly back pain, stenotic, it can be, the patient may have claudication pain. Now, it's because of the degeneration, and this degeneration normally it can start either in the facet joints or anteriorly in the disc. Now, the most common theory that has been accepted to explain this degeneration is that was proposed by Kirkcaldy-Wallace, in which they have divided this degeneration stage into three. The first is the phase of degeneration or dysfunction, in which there are minimal anatomical changes and mostly it's functional abnormalities. Then comes the phase of instability, in which what happens that the disc height decreases, and once the disc height decreases, the facet joints, the capsule of the facet joints become lax and it becomes more mobile, leading to this phase of instability. Followed by, as the disease progresses further, the body tried to reduce this instability by formation of osteophytes and fibrosis formation around the facet joints. Now, when you get an investigation for such a patient, normally this is the MRI, in which we can see there is a subtle slip at the L4-5 level, and on the X-ray, lying down X-ray, this is a lying down X-ray, in which we can see there is not much translation of the vertebra. But once we get a dynamic X-ray of the patient done, we can see that on the flexion, there is the slip of vertebra is quite significant compared to extension. So this makes it unstable. So I'll be talking this stable and unstable quite a lot, because aim of this is at the end of the talk we should be able to say which is a stable spine and whether it's an unstable spine. So how do you decide whether it's an stable or unstable? there are some clinical signs such as back pain is more prominent when it is unstable, and the pain it's mostly mechanical in nature and it increases on standing and extension. On X-ray, this is the measurement that has been that is present in literature, but there is no definite consensus. But we take it for 4 mm translation and 10-degree angulation on a dynamic X-ray. When it is there, then we deem it to be unstable. And we also see on the MRI the facet joint orientation. Now, as I have said earlier, that as the facet joint becomes more sagittally oriented, it predisposes the spine to more instability. There is another factor or term that is called facet joint tropism. That means the difference in the facet joint angulation on the two sides. Now, if there is difference on the two sides, it increases the chances of instability. Now, this is a subtle sign of instability which is present on MRI, that is facet effusion, which is, if present, it's what is facet effusion? So on a T2 MRI, when you get it done, whenever this fluid space is more than 1.5 mm effusion, then it's a sign of instability. Now, this is a sign, facet vacuum, which can be seen on CT scan. So what happens that during the phase of instability, because of negative intra-joint pressure, there is accumulation of nitrogen gas. Now, that is seen as a vacuum on CT scan. Another sign of instability on MRI is synovial cyst. Now, this synovial cyst, it can be because of, it can arise either from the facet joint or it can arise because from the ligamentum flavum. Now, whatever be the source, if the synovial cyst is present anteriorly in the neural canal, it becomes quite symptomatic, and when present, it is a sign of instability. Another sign of instability is a vacuum disc, which is seen on CT scan. One clinical significance that needs to be considered when the vacuum disc is present is that we need to do anterior interbody reconstruction in such cases, because if you do only decompression and posterolateral fusion, then there is an increased chance of pseudoarthrosis. So whenever we see a vacuum sign, we need to consider interbody cases. Now, these are the re-establishment signs, that is osteophyte formation, end plate sclerosis, and ligamentum ossification. When these are present, now we can safely say that the spine is stable. So now we have a patient, now we have got an image, and the patient is having degenerative listhesis. We start with conservative management, and if suppose at the end of, after giving a fair trial of conservative management, if the patient doesn't improve, then we can go for surgery. And the evidence in support of surgery, this is an article now which says that the patient that has been operated surgically, they do well at the end of 2 years and even at the end of 5 years. So once we have decided that surgery needs to be done, now the primary aim is to achieve decompression so that the patient gets relief from his neurological pain. And secondary goal is to maintain his balance and maintain the stability of the spine and sagittal balance. Now, while doing this surgery, now we have two options. Either we can go for standalone decompression or decompression and fusion. Now, to help us to decide whether the spine is stable or unstable, there is this study which have classified the spine into a stable, unstable, and potentially unstable based on the presence of clinico-radiological parameters such as low back pain, restabilization sign, disc angle, and joint effusion. So, if there is a stable, we go only for decompression. If it's unstable, definitely decompression and fusion with interbody. And if now there is something potentially unstable, this is a gray area. In that, it has been said that we can we should go for decompression and posterior fusion. Now, these are the cases of representative cases of stable, unstable, and potentially unstable. Now, during if it's stable, now it's a decompression. If it's unstable, if it's stable, then only decompression. If unstable, then fusion. But now you have seen that there are certain category that is gray area, that is potential unstable. In such cases, if we can get away with doing only decompression, it's always better, because going for fusion in such cases, it adds to the cost and also to the morbidity and also the risk of adjacent segment degeneration. So how do you not to remove this gray area? There is this scoring system that has been put forward by Dr. Kulkarni et al., which have classified the spine in only two types, either stable or it's unstable. If stable, only decompression, and if it's and it's unstable, then fusion. So basically we need to access the symptoms and then go for the images, and then we can plan our surgery. And thank you.
Hello. Thank you so much, Dr. Nisar, for such an informative talk. Now we have diagnosed the case as per your presentation. Now I invite Dr. Gautam how to operate such kind of spondylolisthesis. At the same time, in the meantime, I would like to invite Dr. Rajiv Anand sir, President Spine Society of Bihar, to present a memento to Dr. Nisar.
Good evening to all seniors and dear colleagues. So as we are proceeding from examination to imaging to then degen listhesis, let's see when and how to operate on a spondylolisthesis. So basically there is a past defect and which eventually lead to listhesis, and there is a failure of this hook and catch mechanism which leads to anterior translation of the vertebra leading to listhesis. Whether it is degen listhesis or it is a lytic listhesis, ischemic listhesis or a traumatic. These are various classifications which has been mentioned. The point is when the patient comes to us, then we have to decide as to what is to be done. Both the ladies are almost a year since the treatment has been started. Both are squatting, both are bending, doing all their routine activities. And of this, the younger one has not been operated yet. The other one had undergone a TILIF she had undergone TILIF almost like this case is of 2015 or 16, I think. So long back. So that's the issue. The X-ray may vary, the symptoms may vary. We have to decide on clinical and radiological basis as to which patient actually needs a surgical intervention and which can be avoided. Remember, spine surgery is not about how we operate and how good we operate. It's about when we do not operate. That's the basic crux which everyone should understand. So to know that, we should note the natural history of this spondylolisthesis. It's in the first degree relatives, we see it's almost common as 15 to 70%. Lysis happens to be more common in boys, whereas the slip that is more commonly seen in ladies. Now 15% of this patient, they actually present with a past lesion. It's more seen during the active growth spurt, and mostly after the growth ceases. After the adolescence, there is minimal change in the slip. There is usually no pain during progression, and even some of the athletes, you will be surprised that 18-year-old athletes, they are actually doing all their activity with the lysis in their back and have been conserved and been managed without any surgical intervention. Most of these listheses are actually asymptomatic, and 90% of the slip at initial presentation, they usually do not progress. Progression risk are more seen in patients who are more than 20 years. They are more stable. They have more, those who present at more than 20 years of age, they are more stable, less symptomatic, and they are less likely to progress. High level of athletic activity usually have no effect on progression. association of listhesis with back pain is not very strongly seen. Now the risk progression, which actually alerts us so that we need to take into consideration surgical intervention, these are clinically the growth, if it's seen earlier between 9 and 15 years, girls, they are more commonly to undergo surgery. Back pain, if it is significant, or pain which is associated with gait abnormality, posture abnormality. Radiologically, the dysplastic types, the one with vertical sacrum, if the slip is more than 50% at presentation, or significantly increased slip angle with instability documented on flexion extension, as has been spoken by the previous speaker. So these are the issues which actually need surgical intervention. The problem with spondylolisthesis is you get the foramen stenosis, the exiting roots are stenosed. You may get a central canal stenosis, so all the traversing roots get stenosed, and there might be instability which might be either dynamic or it might be static. And this usually leads to the back pain, the leg pain. It might lead to tingling, numbness in the legs, claudications, and extension catch. So these are all things you should examine the patient and then correlate it with the imaging. So the back pain generators are because of the muscles, the painful powers, the annular tear, or the root compression because of retraction. The leg pain can be because of the exiting root stenosis or the traction on the root because of the SAP is pressing on those. There is an abnormal mobility or the facet and orthosis which is leading to root symptoms. The past scar can also lead to symptoms. Carefully evaluate the history, the symptoms, check out the severity, check out the activities of daily living, and what is the actual expectation of the patient. So these actually help us to know, to decide how the patient should be treated. The sagittal alignment should be seen on the X-ray, and try to get in standing X-ray, flexion and extension. Grade the listhesis, how much it is, what percentage of listhesis slip is actually seen. These are very important, and also important is the sagittal alignment. Why it is important? Because if the pelvic incidence, tilt and sacral slope, all these things has to be taken into consideration. Because if the sagittally alignment is not seen pre-operatively and you don't correct it post-operatively, the patient is bound to have significant low back pain. The patient might go into a pseudo-orthosis which may lead to a revision surgery in future. So all these parameters has to be taken into consideration, and also check out whether the pelvis, when the patient presents to us, whether it's a balanced or it's not a balanced, because if it's not a balance, you might to have additional levels of fixation above. The sagittal balance is so important that the incidence, pelvic incidence, that correlates directly with the severity of the spondylolisthesis. And if you check out the alignment of the L1 vertebra to the S1, if post surgery we don't correct it, the distance is less than 35 millimeter, then the chances of the patient to have significant low back pain post surgery is very high. So this alerts us that if pre-operatively you see this on a standing X-ray, we need to do reduction in that patient. So all these things goes into the management, the decision making, and we have to individualize each and every patient. Think about the natural history, think about the severity, think about the expectation of the patient and the comorbidities. By comorbidities, as has been sir has told before, Parkinson's, diabetes, but also what is of most importance is in today's era is osteoporosis. Either the patient has some drugs or they present late, and we deal with osteoporosis many times. It's not because of surgery, but it's because of osteoporosis that you end up with a failed surgery. So give attention to all these factors. And as with any disease, any disease, we have to first try out with a non-operative treatment in the form of rest, back strengthening exercises, gradually decrease all those factors which are increasing your pain, maintain your truncal strength, and bracing if and when required. Surgery indications are for if the patient presents with severe back pain or leg pain, there is a failed conservative management, abnormal neurology, or a positive diagnostic test. So the indication for surgery specifically in children would be if the patient has got a progressive slip at presentation, the listhesis is more than grade 3, or the pain is persisting, there is significant back pain, the gait abnormality, or neurological involvement. These patients, even at younger age, should be considered for surgery. Surgery options might be either the past repair, decompression alone, or it can be decompression with stabilization. The main goal of any surgery in listhesis should be to provide stability, to achieve neural compression if and when required, and to have a better alignment, and finally achieve fusion. Can I proceed? Yeah. Yeah. And whenever we decide for surgery, there are few things which we should consider, whether we actually need a decompression or not. By this statement, I mean whether we need direct decompression or not, because indirect decompression by jacking up the space we always achieve. Then the types of fusion, whether to do reduction or not, and your technique. So decompression is not usually recommended always, because by doing a interbody fusion, we always jack up the space and you achieve an indirect decompression, you achieve a normal alignment, because of which the roots gets decompressed. So decompression is recommended only if there is a neurology which is present, there is a significant radicular pain, or there is splinter involvement. Regarding techniques, whether you go from front, you go from side, or you go from behind, the main purpose of the surgery is you achieve a good decompression, stabilization, and fusion. Whether you eat with hands, fork, or chopsticks, it doesn't matter. The food should go in your tummy. That's the main thing. So the technique may vary. The point that you have to understand is interbody fusion is such a great thing that by putting a graft in the interbody space, you jack up the space, you recreate the disc space, so you open up the foramen, you decompress the cord, the neural elements, and at the same time you maintain the sagittal alignment, the slips gets corrected, the kyphosis at that listhesis, that also gets corrected. So the overall sagittal alignment, that gets corrected. And this is the beauty of this, because the graft space is so large available over there, whether you buy T-leaf, O-leaf, it is much better, so the fusion rate is much higher as compared to posterolateral fusion. So whether we do by anterior A-leaf or by O-leaf, I think Ayush must be speaking on O-leaf, we'll just skip. So the space is so good that the fusion rate is very high, and whether you do by anterior, posterior, or lateral approach, it depends on your surgeon's preference, what is the familiarity of the surgeon and the assistants, the resources available. The main point should be that your reduction should be achieved as much as possible, and you do good fusion. Regarding reduction, it may or may not be complete. It depends on how much the malalignment or slip is present. You should always aim to have partial reduction so that your sagittal alignment gets corrected. It has several advantages that improve biomechanics, neurological decompression, correction of the lumbosacral kyphosis, and restoration of alignment. And there might be some post-operative side effects which are true for any surgeries, and these are few examples. Thank you.
Thank you, Dr. Gautam. Any questions from the house?
Yes,
I can
sir.
see Weber.
Good evening, sir. My name is Dr. Weber.
Yeah,
So if you do decide to do, let's say you see a patient of high-grade listhesis and you do decide to go for an in situ fusion, what is your preferred technique, whether you go transdiscal or whether you put screws separately at L5 and S1 and then you fuse it? And when you do in situ fusion, whether you do posterior laminectomy and decompression or not, because then you are not jacking up the disc space. So whether if you are doing in situ fusion, whether you do a posterior laminectomy or not.
So usually in all lytic listhesis, I do put cage. So indirect decompression. Yeah.
So, in all lytic listhesis, I will put in a cage. I will do an interbody fusion. So whether you do by MIS technique in which you need not do a laminectomy or you do an open, that depends on multiple factors. But decompression has to be achieved. Without doing that, you won't be able to correct it. He's asking about delta fixation, I guess.
In delta fixation, I have done only one case till now. In high grade, grade 5 that was. So I have done only one. So I don't have too many experience with that.
Okay, so in high-grade listhesis, if you are going to do a delta fixation or not depends on totally on how much lumbosacral kyphosis you have. If you have a good lumbosacral kyphosis, then only you will be able to do successfully delta fixations. But then if you don't have a lumbosacral fixation, if you have a parallel vertebra or if you have a lordotic vertebra, which is very uncommon, in those scenarios, usually your pedicles are not there in L5. So you will usually go to L4 and S1. And there is no interbody fixation. And if you are doing surgery for high-grade spondylolisthesis for claudication or neurological symptoms, you have to do a very, very thorough decompression, because you have to go all the way far lateral, extra foraminal, because your L5 transverse process is crushing the L5 nerve root against the sacral ala. So you have to go till there and then decompress the nerve roots. And then usually you have to do a sacral dome osteotomy also, if you at all you are not reducing also, because you have to take away that edge to decompress your thecal sac. So if you are doing it for neurological symptoms, you have to do a very thorough decompression in situ fusions.
Thank you, sir. I request Dr. Mahesh Prasad, sir, to present a memento to Dr. Gautam.
And one more thing for delta, it should be a balanced spine. Otherwise, you will make him worse. You cannot fix an unbalanced spine with delta fixation.
Thank you so much, sir. Please join me in welcoming Dr. Ayush Sharma to the stage. You will be happy to know that Dr. Ayush is from the land of Bihar and doing very well, phenomenal in Mumbai. He is doing maximum spine surgery through minimal invasive, and he will be talking on most common fracture we come across, that is thoracolumbar fracture and its management. Thank you, sir.
Thank you. It's an honor and pleasure to be here. Thank you, Dr. Shraf and Abhishek. You know, as he told, I am from Patna and Mumbai since 15 years. I always wanted to come back, but every day it looks more difficult that I will be here. I still come once a month to take blessings from my parents, so that is my connection still there with Patna. But it is always, pleasure to be here. So they asked me to talk on management of thoracolumbar fracture. Management means you manage the case. It's not only about surgery. So I will tell you how we manage one case, because in the 8 minutes I cannot teach you everything there to be taught about thoracolumbar fracture. So this is one of our case, a 35-year male. He had a road traffic accident at 9:30 p.m. in evening. The resident calls me that he is unable to move his bilateral lower limb. He also tells me that there is no head injury, abdominal injury. Patient is clinically stable. That means A, B, C, D is stable, and there are no comorbidities. Please understand, for managing this case, this information which is on the slide 1 is vital. First, you should understand what is the status of the case and why this is important, why thoracolumbar fractures are different from other fractures. And if you're listening to my previous speaker, please understand thoracolumbar fractures or the thoracolumbar junction stands between a very, very mobile cervical spine and very, very mobile lumbar spine. And it is a bridge which makes it very, very unstable. So 50% of them are stable and 50% could have neurological deficit. Now, to manage a case, most important is neurological examination. It has already been dealt, but please understand it's a paramount. It's most important thing you should understand. And do the neurological examination, understand the mechanism of injury. Even you have to find out what is the history. A proper primary assessment is paramount in managing this case. Assessment means basics. Go to your MBBS days. Inspection. Inspection means you really need to inspect this patient, because they can have multiple injuries and you might miss one of them. So this is what was earlier talked about. ASIA scoring or ASIA chart is very, very good. If you have this, and if you are orthopedic resident, orthopedic consultant, you must have it. You just need to mark it. Almost everything is there which needs to be known. If you want to know more about it, please read about it. And this is what the ASIA score for this patient looks like. So basically, he's ASIA B because L2 still had some functional power. Otherwise, if you look at it, it's all 0, 0, 0. His sensory was intact. Perianal sensation were intact. Blood retention was there. Reflexes were positive. All this information, which has already been dealt to you and taught to you while they were teaching you the examination, is very, very important, not only to understand the patient, but even to progress the management. X-ray is again the basic which everyone does. Don't do a single X-ray. Please do a proper AP lateral, because this is something you can really miss out. So these are very simple things, but very easy to miss out. This was our case. If you look at it, this is a D12 fracture, and there is a collapse with a kyphosis angle with a Kopp's angle of 32.3 degree. So then, of course, MRI has already been told to you, but this is how the MRI looks like. When you look at MRI, just don't look at the cord. Please try to understand all these things. How different structures are getting impinged, damaged. You have to understand that. So if you look at it, say something very important here. There's a posterior ligamentous complex, and it has gone. Also, always get a CT scan done. CT scan is not only to understand, I always say it's a poor man navigation. It tells you exactly how the fracture is, and a screening CT should always be done in a case of road traffic accident, because it helps you pick up if anything has been missed. You cannot do 100 X-ray, but a simple screening CT will tell you if any other fracture or anything else has been missed in this case. So this was it. You can see the CT. There's a big retropulsion fragment, and even the posterior elements are completely disrupted. Now these are the basic classifications. You can use any one of them. Classification are basically to communicate, but Tillich's is the most accepted when it comes to thoracolumbar fracture, because it not only integrates the bony fracture, but also integrates the neurological status and something very important, the posterior ligamentous complex injury, which it takes into account. If you have a posterior ligamentous complex injury, which is present in this case, it means these fractures are unstable and they need to be operated. Now the question comes, can you give a steroid? What time will you operate? Remember, this patient came at 9:30 in the night. Do you want to go right in? Do you want to wait for the day? Whether you will only decompress, whether you will only fuse, whether you go anterior. We are talking about anterior or posterior approaches. So this is a very controversial topic. Use of methylprednisolone has been in controversy for many years, but there is enough evidence that if patient presents to you early and he doesn't have any significant comorbidity, you can give it if he presents to between 6 to 8 hours. There is decent literature, and we follow that methylprednisolone can be given considering he doesn't have any other adverse side effects or anything. So this was the plan for this case. Patient was given methylprednisolone as per the NACHIS 2. We didn't go mid of the night. If patient is stable, and if I have to do a big surgery, I will prefer a early morning OT rather than a midnight surgery where half of my instruments are missing, even in my setup where we have everything in the world. Patient was taken to the surgery for next day, first case. We planned for all posterior with anterior reconstruction. So this was what was done. First, we went long posterior fixation, and this is the small video. So you can see this is the right, this is the left side, and like they were talking about decompression of the cord, patient is Asia B. It's, as Dr. Srivastava sir was telling, it is important that you do a wide decompression. Now look at this fragment. There's a bony chip which is compressing the canal completely. If you want to take it out with a ronger, you can further damage. What we are using is an ultrasonic scalpel. So it's like a bone cutter. It simply cuts the bone and doesn't damage the dura. So, if you put your ronger, you'll compress the dura further, and look how much the dura is compressed here. So this is ultrasonic scalpel. If you have it, nothing like that. So what you will see is we have, done a box cut, and we'll simply lift off that bone instead of compressing anything. So basically, you don't want to damage anything which is already damaged, and this bone fragment comes out. The second thing is, there is a retropulse fragment, from which is coming and compressing the cord from anterior. So all this is all posterior surgery, but you need an anterior approach somehow. So this is what we did. Again, you can see you can use it, do it with anything, but because we have ultrasonic scalpel, so we took out the facet, and that removing the facet gives you an anterior approach. So once you have removed the D11, D12 facets, you can have the access to the anterior column, and this is what is being done. You have the access to the anterior column, and this is the disc forceps which allows you for disc preparation. So basically you'll see in the C-arm we are exactly at that level, and because all your disc work and everything is gone, I'll take 1 more minute, and then once you have done that, what you can do is you will see that instead of putting a cage and everything in a bad patient, we are just packed entirely with bone graft. So all this bone graft sort of goes in, it packs it out, and then once you have done that, you also need to punch the fragment, the retropulse fragment. You can do it very easily with the L punch. So you see this L punch goes in, and it sort of simply punches the anterior fragment. So that is it, and this is how it was done. And this is the post-op MRI. You can see there's a decent good correction. This is the CT scan. These are all the post-op CT. And fortunately, this was during COVID era. Patient could not come to us in follow-up, but he kept sending us the video of his progress. So we had a video for 1 year how he did. So from power only in L2, in 3 months, this is what he can do. And you see this as we go ahead. This he visited us once. This is 6 months he's walking, and by 12 months, except for foot drop, fortunately, everything improved. Again, don't miss out on chance fracture. Again, thoracolumbar, if you have a big road traffic accident, especially when the patient is on a seat belt, these chance fractures are very, very common. So in conclusion, in spite of, there has been tremendous, improvement and, in technology, in spine surgery, but the management of thoracolumbar fracture still remains controversial. Principal treatment decision is patient specific. You need to understand what is the type of injury. You need to examine that. You need to understand what the neurological status. And it is patient-specific decision which can really make a difference to your patient. Nothing can beat a thorough clinical examination and basic investigation like a X-ray, CT scan, and MRI. Thank you so much.
Thank you so much, Dr. Ayush sir. Now I may request Dr. Praveen sir, who is organizing secretary of upcoming BOACon in Darbhanga. He will be presenting a memento to Dr. Ayush Sharma sir. Now I invite Dr. Gururaj sir. Dr. Gururaj sir is the brain behind this program. He is a senior consultant at Indian Spinal Injury Center, and he has always been dedicated to teaching and training fellows and postgraduates. We are honored to welcome you to the land of Bihar, sir. He will be talking on osteoporosis. And in my experience, most of the cases fail in spine surgery due to osteoporosis. In the meantime, may I ask Dr. Ayush sir, do you use steroids in incomplete neurology with traumatic fractures?
To look at the literature,
yes. Practically speaking.
Practically speaking, if the patient presents within 6 hours to 8 hours, I think there's no harm in giving steroid. Especially if you understand that steroid is not likely to make him worse if he doesn't have history of abdominal ulcer or anything. See, when they have neurological deficit, you try everything in the world and hope something works out. So if that 1% or 5% improvement is there due to steroid, I will take it for my patient. Yeah, please.
Also, sir, regarding punching the fragments anteriorly, there was a belief that the canal fragments are known to remodel over time, and if you get good ligamentotaxis in a fresh traumatic case, there is no need to punch in the fragment. So do you punch in regularly if you see retropulsion?
So if you can punch in safely, see, you have a bone on your leg. If you have a stone on your leg, will you keep that stone or will you remove it? So I understand it will remodel in 6 months, but the cord is getting damaged and irritated every day. If I can remove, so what I'm telling you, if you can remove it safely, and especially it's a compromised canal, I will do everything in the world which makes it better.
The distraction of rods won't help, sir?
So as you saw in this case, so only ligamatostaxis. So please understand, this is a PLC injury. Posterior ligamentous complex is gone. No distraction is going to work. Distraction works only we have a posterior ligamentous complex intact. So in this case, your distraction is not going to work.
Thank you, sir.
Okay.
This is the reference which you are quoting is the radiological journal. It is from the Journal of Radiology. You go to Rothman, it is the textbook of spine. You know, against to this belief that it gets remodeled. You know, remodel occurs in pediatric age group. It doesn't occur that much to the elderly age group. That is one, or adult. Second, Rothman mentions, forget about dorsal spine, dorsal lumbar junction. In cervical spine, if you have to clear the canal, the root recovery of cervical spine happens for even 1 year. If the patient was compressed, you do the decompression and patient's root recovers. Root recovery in cervical spine, one power increase in upper limb, it makes a lot of difference in the rehabilitation. So this feeling that, you know, that this paper is quoted every time, that why to decompress, you are already there, how much time you are going to take to decompress, and be mentally at peace that I have decompressed the canal. It is also mentioned in Rothman that later on there is a canal stenosis. And canal stenosis, there is ischemic changes in the neural structure if you don't decompress. As our spine goes through all this process of degeneration, and there is a cervical as well as lumbar canal stenosis, don't let that space be occupied. Okay. Thank you.
Okay. Once again, I would like to thank the organizers for giving me this opportunity. I'm just not going to go through all the slides and not going to tell you everything. Because this is mainly meant to orient you with osteoporosis and osteoporotic fractures of the spine. So we'll just go through. We know that it's a very, very common fracture, and every 3 seconds you have one new fracture in the world. 1 in 5, 1 in 3 men. On the contrary, to say that it is mainly a disease of women, men also above 60 face a lot of problems with osteoporosis. So the fracture is like, why we need to treat these osteoporotic fractures at the first place is because if you have first vertebral fracture, there is increase of 86% of having a second vertebral fractures. If you have a second, then there is a 3-fold increase. If you have a third, then there is a 5-fold increase. If you have a fourth, then there is a 8-fold increase of having further fractures. So that is why we need to catch them, what we call it as young. We need to catch them early and treat them properly. So osteoporosis is also a sentinel sign of falling health, because it's not just a disease, it's a syndrome itself, because osteoporosis comes with lot of other problems. So it has a downward spiral. Ultimately it leads to impaired function. It leads to increased mortality. That is why we need to treat the osteoporosis. So evaluation, the main thing which they present is with the back pain. So what we have to be very careful in naming osteoporotic fractures, whenever you have fractures above T6, you have to be careful. They can be a pathological fractures. Whenever you have these fractures less than 55-year-old and patients with known malignancies, you have to be always suspicious before you name it as a osteoporotic fracture. And by the by, we should know that this is a diagnosis of exclusion. So you have to be very suspicious. Mostly treated with conservative treatment. Only small subset of patients require surgery. Why are they different? Because they can progressively collapse. Those 10% can progressively collapse and ultimately lead to neurological deficits. So it causes kyphotic deformity, it causes neurological deficits and chronic back pain. Because of these 3 reasons, because of progressive vertebral collapse, pseudoarthrosis and instability. Instability can be of 2 varieties. One is intravertebral, the instability is inside the vertebra, and one is intervertebral, where the instability is between 2 vertebrae, where your posterior ligamentous complex is also failing. So we'll just skip these. I'll just skip these things. Okay. So when is surgery required? Very small subset of patients require surgery for pain relief, to fix the unstable fracture, prevent complications of the osteoporotic fractures like neurological deficits, and improve the quality of life. Various surgical options are available. minimally invasive surgical options like vertebroplasty and kyphoplasty and similar procedures. You can do a percutaneous pedicle screw fixation in them, and then you have open procedures like pedicle screw fixation and maybe deformity correction for kyphotic deformity. That's an algorithm. So you can see that whenever you have a more than 50% canal compromise, you might, it's kind of contraindication for doing minimally invasive surgeries. Whenever you don't have neurological deficits and less than 50% of canal compromise, you can do minimally invasive procedures. Vertebroplasty and kyphoplasty is mainly indicated only for the pain. That is also when you have a direct tenderness over that fractured vertebra, then your kyphoplasty and vertebroplasty results are very, very predictable. Timing is very, very controversial because most of these fractures heal within 6 weeks. But if your vertebroplasty and kyphoplasty results are much better when you do before 2 weeks, because your correction of the kyphotic angle, achieving this vertebral body height is better when you do them fresh. So that is why always there is this ethical dilemma before you venture into doing a vertebroplasty and kyphoplasty. I am not going to sell here vertebroplasty and kyphoplasty because we know that 90% of these fractures do respond to a good conservative treatment. So don't hurry in treating these patients with surgery. These work by mainly structural support and some part of its thermal properties because it burns the nerve endings within that pseudoarthrosis and gives a pain relief. So you have many procedures. First started with doing it in C2, and then you can see that what is the main difference between kyphoplasty and vertebroplasty is, so the cement leakage rates. So you see in vertebroplasty as much as 40% cement leakage rate, but it's not a significant one. If you have only inside the canal cement leakage, that is one is very significant, which can cause neurological deficits. But then most of these cement leakages are anterior and lateral or into the intradiscal, so these are insignificant. Whenever you do these procedures, try to be totally intraosseous. Try to correct the kyphosis or achieve height by positioning, not by the procedure itself. That is very, very important. And try to see that cement leakage is as minimal as possible. So how much volume? It doesn't mean if you inject more the volume, better the success rates. The lesser the cement you inject, better are the success rates. So you have to inject very, very adequate cement into these vertebrae when you do a vertebroplasty or kyphoplasty. If you inject too much of cement, this vertebra goes into osteonecrosis, and ultimately the bone around the cement dissolves and you will have a floating cement ball there. So the difference is, again, we know vertebroplasty is much cheaper, kyphoplasty is expensive, takes longer time. The only advantage is lesser cement leakage rates. So regarding cement, the calcium phosphate cement is very good, especially when you do them in young patients, because it ultimately gets ossified and gets converted into bone. And then you have various procedures like stentoplasty, vesselloplasty. This is available in India commercially right now. Then you have StackX, where you inject these jacks into the vertebral body. And then there is a PEEK Kiva technology, where you thread the rod and then you inject cement into it. Spine jack, this is also flex. So when you have such a situation, when you have done a vertebroplasty, I told you there can be osteonecrosis, there can be further progress of fractures, then you require fixation into these. So what determines your ultimately success of your fixation is fragility of your bone, stability for your spine. PLC intact is very, very important for your fixation, and likely failure mechanism. So pedicle screws fail by toggling, loosening, and eventually they pull out. Hooks tend to pull out, and wires cut out, and anterior struts subside into this cancellous bone. So this is how the pedicle screw fails, by toggling and eventually pulling out. So how to minimize? First thing is to identify there is osteoporosis. If it is an elective surgery, increase your bone density I'll take another 3 minutes. Intraoperatively, try to maximize your hold. We will see how we can do that. And post-operatively, decrease the load on these implants. Delaying surgery definitely helps. Screws, hooks and wires can supplement your pedicle screws. Hook supplementation definitely, because it's a cortical bone purchase. Osteoporosis is mainly a cancellous bone disease. It helps you in stabilizing or supporting your pedicle screws. Crosslinks increase your construct stiffness, but then that can go counterproductive by increasing your adjacent segment fractures. So you have these double threaded screws easily available now. So they actually have a cancellous thread and cortical thread, increase the pull-out strength in osteoporotic fractures. You can use larger screws, longer length screws. You can medialize more. You can cement augment. You can use in-out-in technique, and you can do under tapping or bicortical purchases. So we'll just skip this. Increasing the medialization, you can see there is almost like 30% increase in the pull-out strength. You can do cement augmented screw fixations. This is one of the studies. You have these expandable screws now available. You have these hydroxyapatite screws, and this is not commercially available. This is we are regularly using to do a cement augmented screws. This is a cortical screws. The trajectory is totally different. This is ideal pedicle screw trajectories, but then your cortical screws go from inferior to superior, from medial to lateral. So then now you have available these 3D printed screws, which helps in bone integration. This we have launched and into almost pilot study, and this will definitely give you a good pull-out strength. So are we doing enough? I'll just finish with last slide. No, because most of the surgeons, we treat the fracture, forget to treat the disease. So the very important is to treat osteoporosis, and we all surgeons should know in and out about treating osteoporosis as a medical disease. Thank you.
Wonderful insight, sir. If there are any questions to him, I'd like to invite Dr. Vikas sir to felicitate Gururaj sir. I'll also like to call upon Dr. Avinash for next presentation.
Good evening to all, to respected teachers, colleagues and juniors. Thank you to Saraf sir and Abhishek to inviting me here. So my topic is, it should be I think before the surgery part, but okay, it's the positioning tips and tricks and the role of pre-operative checklist in spine surgeries. So why there is an emphasis on positioning of the patient for a spine surgery? Because if you see a meta-analysis of systemic review of different positions and their complications, they are mainly ocular and cerebral complications like vision loss, postoperative vision loss, connective swelling, hemorrhage, acute closure, glaucoma, diplopia, even a pneumocephalus and cerebral infarction. Apart from this, you can see compartment syndrome of the legs and the orbit and the nerve palsy and thromboembolic complications. Even for knee chest study positions, you can see having our rhabdomyolysis, compartment syndrome and thromboembolic phenomenon. And the complications increase if the duration of surgery increases. So that's why the role of proper positioning is there to avoid and minimize the complications in a prone position. But why it is so much high in a prone position is because there are physiological changes in prone positions. First, there can be abdominal compression, which can lead to increase in IVC, vena cava pressure, which can lead to epidural vessel bleeding or congestion of the epidural vessels. For that, we need to have a free abdomen and reverse tendon of position. There can be increase in FRC of the lung, and that's why there should not be much more padding below the chest so that it compresses the chest and restricts the ventilation. there is decrease of about 20% cardiac index, and also increase the systemic vascular resistance. Therefore, we should avoid hypotension and repeatedly check the pulse and the BP. So in positioning and thoracic, there are mainly three common positions. One is prone, one is knee chest, one is lateral decubitus. Prone is a workhorse. Knee chest generally we use for giving caudal epidural injections or do laminectomy or discectomy, and lateral for only for lateral interbody fusions. So in prone, as we all know, apart from maintaining all the pressure, maintaining the avoiding the pressure at all the points, we need to have a neck in a neutral position with a good support for the head and the eyes. Arms should be flexed and abducted, but not more than 90 degrees, because it can lead to sometimes brachial plexopathy or shoulder dislocation. The chest and the pelvis should be adequately supported, and the genitalia should also be taken care of, that is not stuck between the bolster and the pelvis. And there should be a good position of the leg and the knee, which I will tell later on. Another frame is Wilson frame, where we jack the spine to increase the kyphosis so that the interlaminar window opens up. This is basically done for discectomy and the laminectomy procedures. So to avoid ophthalmic complication, one is the head should be above the heart level, and second is we should always use transparent cover over the head, and we should use such type of headrest where the eye is totally free, not the blue ones, because this gel forms increased pressure over the orbit. This was just day before yesterday, otherwise I have not taken the picture also. You can see the patient is slightly tilted. There's an obese patient. When I came to OT, the patient was tilted. Why? Because patient is so obese. So in obese patients, we should avoid putting borsal like this. And if we want to put a borsal like this, it should be cylindrical one, not a contoured one. Because if contoured one, the patient is not able to fit on the contour and patient tilts. Or we can use a longitudinal borsal to avoid obese patient tilting one side. Compartment syndrome generally seen in the lower limbs or in a knee chest position. There is a gluteal compartment syndrome because there is too much pressure over the gluteus lesions, and it can lead to gluteal compartment syndrome due to rhabdomyolysis, and which later can also cause acute renal failure. So there should be proper padding at the thighs and the abdomen, at the ankle and the knee. I rarely now use knee chest position even for laminectomy or for caudal epidural injection. For lower limb, there should be bolster below the knee for common perineal nerve and above the ankle to make the toes free, apart from other pressure source. Sometimes we need to extend the hip. We generally flex the hip because flexing the hip will decrease the lumbar lordosis. But sometimes we need to extend the hip. One is a case where we are doing a severe deformity cases, because that time there is a risk of plexus or sciatic nerve stretching, or during a high grade listhesis, sometimes doing a hip extension reduces the listhesis by 1 or 2 grade. In lateral decubitus position, the patient will be as straight in one line as possible for a good lateral view. There should be a good bolster at the PSIS and the pubic symphysis, and there should be a bolster between the two legs. Sometimes we should also break the table for increasing the window of the intervertebral disc. As you can see in this, this is totally in one line with a good support at anterior, posterior and between the legs. The complications, it can also lead to brachial plexus injury, sometimes due to over a hyperabduction of the shoulder, ulnar neuropathy, or sometimes asymmetrical ocular pressure due to dependent eye going below the heart level. Preventively, we should always put an auxiliary roll below the chest wall, should do padding between the legs and knees, and should avoid any excess flexion. A bit about endoscopic. Since we need a true AP for our positioning of the scope or in tubular tubes, patient should not be tilted. And again, to avoid tilting the patient, putting a longitudinal bolster helps a better in having a true AP view. And after 20 cases of UV, I realized that simply by elevating the saline and decreasing the height of the table, there is a great increase in water pressure, and many of times there is no need of pump. So I have a extra taller stand for a saline in a case of UVE, so that height increases. And you can see, apart from increasing the water pressure, what it does is there is too much fatigue of the shoulders, putting 2 hours scope from the shoulders, and this increase in height and standing on the stool ergonomically very much helps the surgeon to perform a UV. About cervical, generally for intubation, anesthetists want a hyperextension, but in a case of cervical myelopathies, the spinal canal is compromised, and extending the neck cause infolding and buckling of the ligament flavum, which compromise the cord. So it's better to, you can see in this MRI how the decrease in the hyperextension fall back the ligament flavum and increase the spinal canal space, and that's why fiber optic intubation is better than a normal conventional intubation. And we should always use a tongue, Gardner wheel or a Crutchfield tongue. Generally the patient is at the edge of the head end of the table, so better put a trolley something so that a straight line pull is there of the skull, and the head doesn't go into hyperextension. There should be a pad between the neck, but it should not cause hyperextension again. And sometimes you need to pull the chin up to, so that while putting a screw in a SACF or putting odontoid, it doesn't come in the way. And always a Mayfield clamp is better. Compression is the same as before, ulnar neuropathy, brachiaplexopathy, sometimes there can be tongue or face edema or airway kinking. In prone position, the head end should be slightly up to avoid any post-operative visual complications. Neck should be slightly flexed to about 10 degrees for a better exposure of the posterior spine. The chin should be away from the chest. The head should be on the Mayfield. It can be a translucent table also, and adequate supporting of the chest and the pelvis should be there. The shoulder should be pulled downwards by a dynaplast or something like that, so that it doesn't come in the way of our C-arm viewing, and a proper fixing of the patient to the table is required. The neurological complication of is the same, which is already been told. A little bit about checklist. Just one thing, a checklist is very important, though it sounds very trivial, but having a good checklist helps in better post-op outcomes. And this paper everyone should learn by my mentor Kulkarni sir. Here 37-point checklist is there. You can go through it. Importantly, this checklist includes the positioning as a factor for a consideration before taking the case, which WHO checklist doesn't have. Thank you.
Thank you, Dr. Avinash. Thank you. I'll request Dr. Ramasis Yadav sir to come over the stage and felicitate with a memento to Dr. Avinash. Now I request Dr. Vaibhav Sinha, a very good friend of mine. He will be talking on know your tools and weapons during spine surgery. He will be talking on that.
One announcement for postgraduate students who have not registered for quiz competition. Please come near the facilitation dice and get yourself registered if you have not registered. I request you all to participate in huge numbers.
Good evening, everyone. So after so much of clinical discussion, I am here with a very dry topic, implants. So coming on to the first implant, so we all know about titanium pedicle screw. So they are used predominantly in spine surgery because of their higher corrosion resistance, acceptable biological compatibility, and low elastic modulus. So the benefit of a lower elastic modulus comparable to bone is that it prevents stress shielding. So when the elastic modulus is closer to the bones also get to share the load. And then it provides rigid spinal stability and also promotes bone ingrowth. Then what are the problems with titanium? So when it comes to imaging of the spine after a spine surgery, when there are screws already inside, so compared to stainless steel, it obviously has less artifact, but titanium still has a lot of artifact when it comes to post-op imaging. So you can see how the titanium screws shine up when there is a post-op imaging, and these interfere with assessment of biology and the assessment of fusion rates in these patients. Then there is also the problem of wear and corrosion and the difficult implant removal after a long post-operative period. Now coming on to carbon fiber technology in spinal implants. So these are more biocompatible, they are bio-inert and lightweight. Also they have comparable strength to titanium and stainless steel, and they have excellent corrosion resistance. And there is a new technology in which there is a carbon fiber reinforced peak. So this allows a semi-rigid stabilization. So as the construct becomes less rigid, there are less chances of adjacent segment degeneration and other complications. So there is a specific role of CFR peak in spinal oncology. So as we know that the patients of spinal tumors have to be subjected to radiotherapy. So when there is the radiolucency of this implant reduces the radiation scattering and tumor shielding due to which is caused by the metallic implants, and therefore it allows better dose calculation for post-operative radiation therapy. And then there are other technologies in the spine which increase the mechanical stability of the screws, such as mentioned, dual threaded pedicle screws, which enhance stability and pull out strength. So there is both the cancellous and cortical component to the screws, which provides the double benefit of increased pull out strength, and it engages more bone in its threads. Then there is a fenestrated pedicle screw which is used extensively in osteoporotic patients. So these have a slit through which the cement can be pushed, and it allows better hold of these screws into the osteoporotic vertebrae. Then there is also the technology of expandable screws. In this, the distal 2/3 segment of the screw, when it passes through the pedicle, we can expand the screws and then it can be advanced so that it engages more bone in the osteoporotic spine. So all these technologies of fenestrated screws, expandable pedicle screws, these are very beneficial when it comes to fixation in osteoporotic patients. Now coming on to plates, we all know about titanium plates which are used in anterior cervical discectomy cases and fusion cases. So these are compact, affordable implants, and it is excellent for rigid attachments. These are locking plates, so when you tighten the screw into it, they are locked into and they work as a single unit. So the chances of screw backing off are usually less when it comes to locking plates. Then there is something known as bioabsorbable cage, which are coming new into the market, but I don't think there is widespread use into clinical practice right now. Coming on to rods, there are three types of rods can be rigid, semi-rigid, and these stabilizes the spinal column and they reduce kyphosis, scoliosis, and they improve arthrodesis rate because of their stiffness. And then coming on to cobalt chromium rods, so compared to titanium, so you must have heard about cobalt chromium rods in deformity surgery, and they are better in deformity cases because cobalt chromium rods are more rigid. They don't yield to the deformity much. So when you are correcting rigid kyphoscoliotic curves, a cobalt chromium rod will help you better, and they transfer higher corrective forces onto the spine with decreased deformation. But they also have the problem of increased stiffness. Cobalt chromium is one of the most stiff implant in the implant armamentarium, and because of this increased stiffness, it leads to increased stress shielding, which means that it doesn't allow the surrounding bones and to bear the load, and it takes the entire load on itself. So there is also the problem of increased stress shielding with cobalt chromium rods. Then coming on to memory rods, which is obviously it's made up of nitinol, not very commonly used in spine surgery at present. Then coming on to cages, these are vertebral body interbody devices, so which restores disc height. We have all seen how they can restore the disc height, and Dr. Gautam Prasad has explained how we can get foraminal distraction with using these cages. So they provide indirect decompression. So you're not directly decompressing the nerve root, but because of the jacking up of the disc space, the nerve root and the neural foramen opens up, and it corrects coronal and sagittal alignment because these cages can have lordotic components to it. So when you see these cages, they come in either 0 degrees or they can have some 7 degrees of angulation, which can help you restore the sagittal alignment better. And there is also slope in the coronal plane, which can help in correcting coronal plane deformities. So based on the implants, cages can be made up of titanium, which is obviously a strong biomaterial with low density. It has good corrosion resistance, and they have high fatigue strength with lower stiffness. But there is a new implant which is also very commonly used, which is known as PEEK. PEEK stands for polyethyl ether ketone, and PEEK and bone have equivalent Young's modulus, which means that there is less stress shielding, but they are also fragile and can shatter during cage implantation. Doping techniques such as vapor deposition and titanium plasma spray can improve mechanical properties of PEEK. Now the benefit of PEEK is that it is radiolucent, and it allows surgeons to check for implant migration and success better, and you can see the fusion rates more clearly. and it has a lower compression strength compared to titanium, but it also has lower cage subsidence rates. Now coming to a new technology which is known as silicon nitride cage. I was also not aware about this. When I was reading, I came to know that it has a higher strength, it has osteoconductive properties and mechanical reliability, and it has improved osseointegration and new bone ingrowth on it. Yet to enter the market in a big way, but there is also carbon fiber reinforced polymer cage, which is obviously 70% PCAN, 30% carbon fiber, and it also prevents stress shielding phenomenon due to comparable stiffness. So you at least should know that whenever we talk about Young's modulus of elasticity or stiffness, the lower the stiffness, the better it is, because as you also know, in cases of arthroplasty, if the implant is very stiff, it will cause stress shielding and it will make the surrounding bones weaker. So the implant should not be very stiff, otherwise it will lead to future problems. Then coming on to these were the slides about implants. Coming on to new technology and instruments in spine surgery, as Dr. Ayush had showed us how ultrasonic bone scalpel can help us in doing laminectomies, and there will be, you must understand that when you use ultrasonic bone scalpel, you are going out to in. You don't need to push your rongers inside the dura and pull the bone off. So that advantage is obviously there, and it uses high frequency, low amplitude ultrasonic vibrations, and it only cuts the hard part, the bone. It will not cut the dura. So coming on to the endoscopic spine surgery, biportal versus uniportal, I obviously the speaker after me is going to talk about it. So there is excellent anatomic visualization. It is unparalleled. Nothing microscope can compare to it. So there is excellent anatomic visualization. There is reduced risk of infection because of continuous irrigation, and obviously the learning curve is steeper, but once you learn it, it is quite beneficial for the patient as well as surgeon. So this is how the uniportal and UB looks like. On the left you can see that it is a uniportal surgery in which both working and the visual portal is the same. So you are putting instruments through the same portal through which the scope is there. But if you see the other image, there are two portals which we make, and we triangulate both these portals. So the surgeon is using his left hand as a visualizing portal and the right hand as the working portal, and you have to triangulate these instrument inside the body. And then there is a technology of navigation and robotics in which we use intraoperative CT scan to get an image, and then we transfer these images onto a stealth station where you can plan your screws, and then the robot, which is shown on the right, can plan the trajectories, and you just need to pass the instrumentation through it. And then there is augmented reality in which we project the 3D navigation data and the patient anatomy directly onto the surgeon's view. So these are the new technologies which have come into the spine surgery scenario, and we should be aware of all the new advances in spine care. Thank you.
Thank you, Dr. Vaibhav. I request Dr. Alokandan Jha sir to come over the stage and present a memento to Dr. Vaibhav. Next talk is very interesting. Dr. Anupam, very good friend of mine. Recently he has conducted WestCon, World Endoscopic Society Conference at Gaya, very successful conference, and he will be talking today on Destandu's endoscopic lumbar discectomy. He will be talking about the technical pearls about it.
Good evening, everyone. Thank you for having me here. I do Destandu's endoscopy, and I'm going to illustrate a case of mine as to take you through as to how I do this. So before I begin, I'll have to mention this person, Dr. Jean Destandu. They call him Jean Destandu at France. He's from Bordeaux. He is the one who revolutionized endoscopic care. He brought the concept of laparoscopy and triangulation to spine surgery in 1993. He has of late taken retirement. He has bought a fancy yacht and he sails around English Channel, and he is away. I mean, he used to come to India pretty frequently, but now he is away. So this is what he designed, his endoscopic tubular sleeve system, and this was marketed by Karl stores world over. So this is basically a tube system where there is an outer elliptical tube which has a working insert with which through which we can operate, and it has 4 channels, one for the scope, one for the cannula, and then another 8 mm for your instrumentations, and there is an integrated nerve root retractor, and this is the commercial version of it and how it looks. So it's a targeted treating device where we dock it at the site of pathology. So choosing your case in a right manner is very important. On the left, you can see that Dr. S.K. Srivastava sir's slide as to where do you find your disc. So this is where we dock, and there is an inherent angle between your instruments and the scope. So your instrument tips are always, you always have a vision of it. So the safety is greatly enhanced. So what's the beauty of it? It's a mobile system. It's not a fixed tube. So you can turn it in any direction. Your hands are virtually free. The scope is attached to the sleeve system itself. This is a representation from MISAPCON 24 where we conducted the Standu's station on a porcine model in Gandhinagar. So why endoscopy? I think Dr. Ayush is going to take a video demonstration of that in coming lectures. But then again, just to mention, to reduce collateral damage, to prevent causing an iatrogenic instability and do a motion preserving surgery. We are moving away from fusion day by day. When you go to Japan or Korea or Asian nations, I think the concept of preserving your motion and the indications for your fusion should be very, very strong. The ability to do over-the-top decompression through a small incision and a small laminotomy, and taking in care of adjacent segment diseases in young population, say the rate is 3% per year and you are seeing 5 or 10 years down the line in a young patient. So minimizing all this, and that's how the concept of Destandu and then the other derivatives like all inside, full endoscopic, UB and all came into being. So going to illustrate a case of mine, recently done last month, a 32-year-old young male. You can see he was suffering for 6 months from intense claudication radiculopathy, left-sided predominantly. He had exhausted all conservative treatments, and it was affecting his ADLs very significantly. So you can read an MRI, L5S1 disc, posterior central, and he has tried epidural injection from pain specialist and all, but failed. So we did dynamic X-rays to rule out any instability. There was none. We marked in our level, since it's a targeted treating device, so you have to know where your level is. If you don't mark your level well, so you're gonna face a lot of problems. So this is the localization device, and we need only couple of shots, lateral views, no AP shots required. And this is the skin marking. You can see our patient is in knee chest position. We don't need any fancy tables. They are modifications and bolsters made by Dr. Jean Destandu and Dr. Rohidas himself. And we can place, these are pics straight from my OT. This is a pic from another patient because I was not able to take pic for this patient. But this is how we place, typical of any spine surgery, free abdomen, head lobe, hypertensive anesthesias and all. And this is how our theater setup looks like. In this particular case, we went from left side, patient is in prone position. The Mayos is on head end, and I have, there are hardly 10 or 11 instruments in this procedure. So this is a set with the least recurring cost. I have monitors on all the walls so that my assistant, my anesthetist is able to see the vision constantly. So we went in, we docked our tube, and this is what we intend to see. When we get in, so you should be able to see your superior lamina, your interlaminar window, as well as your inferior lamina. So this is what you intend to see, but when you begin in, what you see is a red out zone. When you go in, you just see blood when you begin with, but then that improves with time. So you'll have to spend some time on training. So then we start taking our bites. 345, 390, 245, 290 are the standard workhorse. I mean 3 mm and 2 mm rongers. So we insinuate very gently below the superior lamina, and you can see the underlying yellow ligamentum flavum. So once you have created adequate fenestration, you start putting in your cottonoids. You have to learn how much pressure to put so as to delineate the superior flavum which is attached on the undersurface of superior lamina. So this is For orientation, this is L5, this is S1, this is your midline, and this is your facet joint. This side is your facet joint. So you can see that I have put in my cottonoid well below the flavum. I'm able to create a safety net so that when I'm going to take my flavum out through my rhongia, there are less chances that I'll harm my neural tube. So as you can see, so you can take out your flavum piecemeal, or you can take it out as a butterfly. There is a very big craze about taking out your flavum as a butterfly for endoscopists. So after I have done my fenestration and I have removed my flavum, this is the picture I get. In this particular case, the MRI you saw, this is an axillary disc, this is your neural tube, again midline, lateral. This is your S1 traversing nerve root. See how beautifully you can see. And this is actually, this is a video wall. When you'll see it on an actual surgical screen, you will feel that you're so close to it. So it's a good morning disc asking it to come out. And this is what is causing the symptomatology. So we palpate through it, we get a feel of it. It's a supple disc, but yes, it is causing all the symptoms. You can see the S1 root, traversing root. So we went in, we used a trephine, and we popped it open, and you can see the glistening white material which is coming out. So we try to take this out in toto as one entity, and the beauty of it is that whether it is a central, paracentral, foraminal, extraforaminal, up migrated, down migrated, whatever disc, you can do it very well. You can go everywhere, hook and nook, see for free fragments, reduces the chances of recurrence, and that's why it's a very versatile system. So at the end of it, after completing my discectomy, you can see the rent in the annulus there, the free S1 traversing nerve root. I have gone till the foramina, I have decompressed it. I don't have the video to show what I did over here, but yes, this is the neural tube. I can go over the top on the opposite side as well, but since the patient didn't have symptoms, I didn't go. So after the decompression, you can see the pulsations, how free it is. Couple of minutes more. How free it is. How free is your S1 traversing nerve root. In fact, I am seeing the S2 as well here. So that is the beauty of the system, how well you can. And I have not touched the facet here. The index surgeon says that you can remove 1/3 to half the facet as well. It will not cause significant instability, but we have not touched the facet. So this is the final pick. This is the amount of disc which has come out. Half a butterfly I was able to do. Another case I did yesterday. This was 10/10. I discharged this patient today morning, a young female anxious to conceive, recently married. We had disc over shoulder as well as over the axilla, and we were able to decompress both. Wonderfully, big disc came out again. Another of my patients, L4, L5 down migrated, 2-year-old patient of mine, doing good, big disc came out. So scope of this, I can do disc, as I said, all kind of disc. I'm not limited to only say foramen or say central. I can do extraforaminal. So that's the versatility of it. I can do multi-level stenosis. Desando has evolved as to go on to have fusions. A recent paper was published by SGPGI, and they have expanded Desando to fusions. They are putting in cages, tumors, cervical spine, and everything. Yes, we concluded WestCon, Dr. Abhishek. Thank you so much. You were there. Dr. Saraf was there. Amulya sir was there. He honored us. Mahesh Prasad sir was there. So everybody was there. So we had a great time there. We had good congregation for West. We conducted our endospine courses in Feb 2025. And with this, I'd like to close. The next WestCon is at Bali. And those of you who would like to join, I mean, being the last center which we did it, I mean, you are most welcome to join, and we'll see how we'll accommodate if you want to present your work. Thank you so much.
Classic presentation as expected from Dr. Anupam. May I request Dr. R.K. Prasad sir to present a memento to Dr. Anupam. He has come all the way from Gaya. Our last talk for the session, and after this is the video presentation and PG quiz session also. And the last talk is by our phenomenal surgeon, Dr. Amulya Kumar Singh sir. He is live wire of our association, that is Bihar Orthopedics Association, always ready to teach and train, always ready to guide juniors, and our president-elect of our association. He has reached despite of many pre-commitments, and I thank you really, sir. And he will be talking on a very important topic, which is patience of our patients, how to deal with it. I will add patience of our patient as well as our listeners. So, how to deal with it?
Good evening, everybody. After listening to such interesting topics from the brilliant speakers as such, talking something differently, why I'm saying that, unless your patients have your patients, they are not going to become your patients. You are not going to show your skill, what you have learned in your UG and PG days as such. So, our interest in our clinical practice is that वो पेशेंट जो भी गलती से आपके पास आ जाता है वह आपका पेशेंट बन के रह जाए, एंड उसके लिए यू हैव टू वर्क अ लॉट बिकॉज
In the meantime,
yeah, sorry.
Please carry on, sir.
And these patients, what I was saying, how to deal. An average orthopedic surgeon like me, I'm here to tell you, because every doctor wants to succeed in life with high aim. When I passed out, when I left Armed Forces Medical College way back, I wanted to succeed. I also wanted to succeed in life what the other senior people, Dr. Upendra Prasad, Dr. Saraf sir have done with their knowledge and skill. My professional journey started with this patient who paid me ₹5 about 31 years back. She was happy at that time. I was happy as a doctor that I could convince the patient. Later I realized I'm running for my life. My old patients are not loyal to me. My old loyal patients are getting impatient. And the impatience of my patient gradually affected my mental and physical well-being. As number of patients increased in my hospital, I realized life is not easy for doctors. Society has got lots of expectations from us. My loyal patients are getting impatient, and this impatience of my patients are giving me more tension and stress in my not only personal life, even my family and social life as such. I started following my patient's life. Friends, I noticed everybody is stressed, therefore impatience is increasing in society. How to deal with the rising impatience of patients? We have gone through these books in our UG days and PG days, but unfortunately, you won't find them in any of your textbooks, how to make your patient a good patient. Champions are not made in the gyms. Champions are made from something they have deep inside them, a desire, a dream, and a vision. This was said by Mr. Muhammad Ali, the world champion. So with these wisdom of knowledge, I realized that I have to satisfy my patients, make them happy by reducing their impatience. What is patience as such? Patience is actively waiting without pain and grievances. I'm talking as far as my OPD patients are concerned. Not passively waiting, that is laziness. Patience is waiting for just the right moment before they are ready to screw the doctor and my staff. And this is derived from a Latin word pati, which literally means to suffer, to bear, to endure. And no wonder the Indian husbands are referred to as Pati Dev, because we are really patient from mind and heart. How we feel when we are patient, lots of disturbing features are there, and similar is feeling of our suffering patients when they are in our hospital. For consultation, when we are coming to the OPD, a patient has to go to different places in my hospital, and patient may become impatient at all the places as such. Patience is not the ability to wait, but the ability to keep a good attitude while waiting. This was said by Joyce Meyer. Hospital management does not realize the problems faced by the patients. When we are sitting in our AC room, we do not realize how much impatience our patients and attendants are. What management feels, patients should sit quietly and wait without expressing anxiety, tension, or frustration. Patients should be always calm and cooperative. Overall perception, as the literature suggests, in any of the visit, 60% the green line is good, the dark blue 16% is excellent, red and the maroon line is satisfactory, and 6 is poor, blue line. But more than 6% of poor perception sends a bad impression of a hospital. Even if you're satisfying 94% of your patient, 6% of your impatient patient can give a bad signal of your hospital. Negative consequences of being impatient are that patient attendants get upset, easily lose temper, they ignore all the good work of the past, start shouting, staff and other patients get disturbed, doctors get stressed, and further delay and confusion is there. The quality of care suffers, leading to bad reputation of the hospital. What Mahatma Gandhi has said, to lose patient is to lose the battle, and you are going to lose it in your life, in your practice as such. So find the problem. Sometimes it's hard to pinpoint exactly where your daily schedule is creating problems to your patients, sending poor perceptions. So design a survey to identify your problems. What is the reported data of complaints when patients are getting impatient? A big list. But in summary, what is there? Generally, females are more impatient. Males are impatient on support staff behavior and waiting time. And waiting time is most important. The most important reason for losing patient in OPD is increased waiting time. You call a patient at 9 a.m. and you see the patient at 11 a.m., the patient gets disturbed. So waiting time refers to the time a patient waits in the clinic before being seen by the doctor. Patient clinic waiting time is an important indicator of quality of services offered by the hospital. Long waiting time, this is in my OPD. In 2019, most probably 4th of April, what was happening? Patients were waiting there, I don't know for how long time. This patient is now coming to the chamber, he is now getting disturbed. One patient is getting disturbed, within seconds or minutes you will find how many agitations other patients are going to make. Just see it's a live video which I captured from my CCTV camera. My staff is trying to explain this patient that within minutes or something, maybe half an hour, my doctor will consult you, and soon the patients are now getting agitated. The other patients are now supporting this patient, and they are now shouting, yes, agitation is increasing. So what is the solution? Reduce the waiting time and make sure that the patient receive the right care at the right time. In turn, this will improve the patient perception, reduce the cost of care. Why patient fails? Because there is a gap between expectation and performance. What we as a doctor, our staffs are doing. So delight is what, if you are able to fill this gap, then this is called delight, and the patient is never impatient in your OPD. The Institute of Medicine recommends that at least 90% of the patient should be seen within 30 minutes of their scheduled appointment time. Several studies have shown that patients spend 2 to 4 hours in the OPD before seeing the doctor. This is the most important reason for the impatience and create a poor perception of the hospital. We should try to get a balance between the demand and supply of appointments, what you want to give to your patients, and online check-in solutions can be done by online system. E-patient portals can be made, but that has to be very much simplified. Encourage your patients to schedule your appointments for the early morning slots. Just like the first flights are usually on time, the morning appointments of the day are usually on time. Supportive staffs, all staff should be decent, well-mannered, caring, and supportive to the patient concerned. Have dedicated staffs for each responsibility. This will avoid unnecessary confusion. Front office staff members are our first impression, sometimes the final impression, but request your reception area staff to be away from your smartphone mobiles. Make sure that you do staff maybe 2 to 3 minutes more. They report at least 30 minutes before the first appointment to avoid confusion. List of appointment along with the tentative reporting time should be finalized and duly intimated to the patient and doctors. Any last minute changes should be brought to their notice as early as possible. A priority, naturally VIP patients are going to come to you. If you are a good doctor, big name, they are going to come to you and they have to give in some priority. And delay should be announced by the public address system with due apologies and regret. Set a time limit for late arrival. If patient has taken an appointment, he is late, then you have to find out what we are doing for our tickets. All organizations like airlines, etc. are implementing this. Why not in hospital? The first impression of hospital is very important. Reception inquiry should be near the entrance. The OPD should be really readily accessible. Signages should be displayed at strategic location. Washroom should be prominently displayed and clean. Waiting area should be large enough to accommodate the patient's attendance. Proper arrangement for lighting and ventilation. The waiting area should be displayed. General information of public interest. Facilities, we do require TV, newspaper, Wi-Fi zone, what you get at the airport. Large aquarium with attractive fishes, arrangement for refreshment and pure drinking water. Doctor interaction, the patient has waited patiently for you for such a long time. Talk and talk to your patient with smile. What the literature suggests in India, after 19 seconds, when the patient has waited for 3 hours or so, he comes to your chamber within 90 seconds. मेरे जैसा डॉक्टर बोलता है हाँ मैं समझ गया चलो मैं दवाई लिख देता हूं within 90 seconds. This is the documentation, not my data. So make a good eye contact. Patient wants to interact with you, not to your staff. Give your precious but precise time. The patient has waited. The body language approach can cut down the impatience by your good behavior. It has been proved beyond doubt that the communication skill of a doctor is more important than his technical skill and knowledge to impress the patient. What Dr. Ayush, Dr. Srivastava and others people have impressed to you. Yes, they have best knowledge. But first, you have to satisfy your patient. Then only he is going to be operated. If the patients are impatient after a long waiting time, this art of communication of doctor and holding hands can bring back the patients. Consultation times, our valuable time should be utilized with proper interaction with patients attendants. Our assistant can help us in additional documentation tasks. Each minute is precious. Utilize your time judiciously to satisfy and convince the patient. Counseling staffs have to be there to counsel. Most of the time, you cannot do everything. Also, counseling staffs have to be good. Patients can come for opinion by our marketing efforts, but retaining them as a permanent patient is our talent. For this, reduce the impatience. Can you succeed? Yes, we have to satisfy them. Remember that lots of impatience are a bad sign that brings bad repute of your practice, and there is risk of losing revenue and patients. Listen carefully, be responsive, understand the need, expectation of patient, work on your brand image, encourage patient feedback and measure and improve. So being a successful doctor is more about maintaining patience of our patients than our skill and knowledge. Care more about the individual patient than for the special features of the disease. Put yourself in his place. The kind words, the cheerful greeting, the sympathetic look, these the patient understands from you. Focusing on patient satisfaction, patients will come and go. Some will test you, some will love you, some will leave you, and some will bless you. But as a doctor, be patient and bring the solution. No one really has a bad time. What Regina Brett has said, not even a bad day, just bad moments. So you can improve yourself. Try to change slowly but without losing charm in life. So these all 8 elements are very important for you when you are talking to your patients. And when you satisfy a patient, this brings good satisfaction and good repute to your hospital. If you satisfy one patient, that reaches 4 new patients. If you dissatisfy one patient, 10 potential patients are lost in the society. So what we have to do? Dream the impossible. Know that you are born in this world to do something wonderful and unique. What Sri Sri Ravi Shankar has said. For reducing the impatience of patient, don't work for money. Try to serve the patient and society with patience. Money will come automatically as a byproduct of your patience, sincerity, devotion and dedications. What Roger Federer said, when you are good at something, make that everything in your life. And our own patience to reduce the impatience of our patients builds our own reputation, relationship, and reach in modern health care where we are sitting today. A man who is master of patient is a master of everything else, what Lord and Halpin has said, and this is my team with whom I am working at present. I tried to implement everything in my life and my patients so that my staff behave like what? Your patient is your net worth. and your brand as your image in the society. So work for it. You can become a successful doctor that way. Thank you so much.
Thank you so much, sir. Now I invite Dr. Professor S.N. Saraf, past President Bihar Orthopedics Association and current President of Mithilanchal Orthopedics Association, to felicitate our President-elect Bihar Orthopedics Association, Dr. Amulya Kumar Singh, sir. Fantastic talk, sir. I really wish that our staff also follows the same. Alka, तुम्हारे लिए है especially, ठीक है? Now I hand over my mic to Dr. Priyanka, who will be holding the inauguration function.
Before that, we'll start the quiz, the first round of the quiz. I request you all who are interested to participate in quiz to come into the next hall. Just for your information, all 3 winners, we firstly will eliminate 5 persons. Out of that, we'll have rapid fire. And the first 3 winners will have a fellowship of spine at 3 best centers in India. One in Mumbai, affiliated with AO Spine. Second is Indian Spinal Injury Center, New Delhi. And third one will be CISRO, Patna. That will be, and you will be getting a to and fro ticket by AO Spine and S.N. Saraf Hospital, Darbhanga. So I request you all who are interested to participate in quiz to please come to the next hall. Thank you.
All the best to the quiz participants. And good evening, ladies and gentlemen, esteemed guests and fellow medical professionals. It is my honor to welcome you all to the AO Spine hospital-based seminar on degenerative base, lumbar spine and technical videos. And I am very happy to see a huge crowd in this leisure evening. As we gather here today, I would like to acknowledge the efforts of the organizing committee for bringing together a diverse group of experts to share their knowledge and experiences in this field of spine surgery. The agenda for today's seminar is comprehensive, covering various aspects of degenerative lumbar spine conditions, from clinical examination and imaging to surgical techniques and management. We have an impressive lineup of speakers who will share their insights and expertise, and I am confident that the discussion will be informative and thought-provoking. With that, I would like to formally inaugurate the AO Spine hospital-based seminar with the lamp lighting ceremony, and I would like to invite all our esteemed faculties to come on the stage for the lamp lighting ceremony. Dr. S.K. Srivastav sir, Dr. Gurraj sir, Dr. Ayush sir, Dr. Rajiv Anand sir, Dr. Mahesh Prasad sir, Dr. Amulya Singh sir, Dr. S.N. Saraf sir, Dr. Vikas sir, Dr. Upender sir, and Dr. R.K. Prasad sir to come on the stage and do the lamp lightnings. Thank you so much, sir. Thank you so much. And with this, we would like to felicitate our speakers who has come from all over. And first of all, I would request Dr. S.N. Saraf sir to come and felicitate Dr. S.K. Srivastav sir. आगे स्टेज पे राम कुमार रहने दो Thank you so much, sir, for coming all over the way to enlighten our students and guests. Now, I would request Dr. Upender Prasad, sir, to felicitate Dr. Ayush, sir. Dr. Upender, sir, is the current president of Bihar Orthopedic Association. And Dr. Ayush sir is also from Patna. I would request Dr. Rajiv Anand sir to felicitate Dr. Gururaj sir. And I would request Dr. Praveen Kumar sir to felicitate Dr. Rajiv Anand sir. Praveen sir? Dr. Praveen sir. Chale? Dr. Ramashish Yadav sir. Is the current HOD of DMCH, so you can hear it from the applause given by the PG students from behind. And I would request Dr. Abhishek Saraf to felicitate Dr. Anand Shankar sir. And I would request the whole and soul Mrs. Sudha Saraf to felicitate Dr. Nishar Ansari. Nishar sir? And Mummy, and I would request, I think Nisar sir is not here, so I would request Dr. Gautam Prasad sir to come on the stage and being felicitated by Mrs. Sudha Saraf. ज्ञान सर Next, Dr. S.N. Saraf to felicitate Dr. Avinash Kumar sir. Dr. Nishar has come, I think. I would request Dr. Alokanand Jha sir to felicitate Dr. Nishar sir. And I would request Dr. Ram Sagar Pandit to felicitate Dr. Vaibhav sir.
Praveen sir, Anupam ka Dr. Praveen sir.
And I would request Dr. Praveen sir to felicitate Dr. Anupam sir.
डॉक्टर इजाज आया हुआ है, डॉक्टर इजाज से करवा दो, अमूल्य सर को करवा दो, डॉक्टर अमित से करवा दो।
I would request Dr. Amit sir to felicitate Dr. Amolya Singh sir.
Amit. Thank you so much. Best regards. Yes. नहीं सर, इजाज हमको
And I would request Dr. Ijaz sir, who is a very famous neurosurgeon of Darbhanga, to felicitate Dr. Mahesh Prasad sir. I would request Dr. Nipender sir to felicitate Dr. Mahesh Kumar sir.
कंटिन्यू करा दो। नेक्स्ट टॉपिक इसका पहला।
Thanks to everyone for coming to this in this leisure evening of Sunday and making this program successful. And with this, let us continue this journey of learning and knowledge sharing. And I wish you all a productive and enriching experience. Thank you so much. Let's proceed with the seminar. I think the video presentation is there by Dr. Mahesh Kumar.
Friends, this is a wonderful procedure, transforaminal epidural steroid injection, and as it goes, it's a magical cocktail, and majority of our lumbar spine problems can be resolved. It's a kind of supplementary therapy in conservative approach, as Srivastav sir has told, and before any surgical procedure be undertake, this is something that must be tried. And
just 2 minutes back to this patient, and we will be interviewing the patient right
this is
now.
actually presentation of Abhishek, and he has been doing it, and this is the recorded video. Since we all work in the same hospital, and this is what.
अभी आपके दर्द में 10 मिनट पहले जो दर्द था और अभी जो दर्द है, दोनों में कुछ अंतर लग रहा है? 75% इनका दर्द ऑलरेडी जा चुका है, तो पैर हल्का लग रहा है आपका? इंजेक्शन से पहले आप कितना दूर चल पाते थे?
So the effects are mostly immediate, within 10 to 15 minutes. Most of the patient document relief of the symptoms, although bit paresthesia and numbness is there in the respective dermatomes, but relief is almost immediate.
We will be showing it up in the GovCon 2 days later. Thank you so much.
So it has to be with a clear purpose, and there is a definitive technique, and then associated video will follow. And compressive radiculopathy is the indication. Pain which is along the nerve root, typical defined abdominal pattern that we have to clinically examine, and there is a sensory dysfunction, motor deficit, anything has to be documented. Rarely it can be indicated for cardiac venous syndrome, but obviously that is surgical intervention which is more appropriate for those conditions. Acute radicular pain, and from my own clinical practice, which I can say is that if the pain is so severe, apart from medications, we must go for transforaminal epidural steroid injection in the combination with drugs at the outset only, rather than waiting for weeks for medicine to act or physiotherapy to relieve the patient symptoms. We can directly go for TS because it's such a safe procedure, simple procedure. It just hardly takes 5 minutes, and patient gets immediate relief. And randomized clinical trials indicate that nerve block is a cost-effective procedure in the majority of cases compared with other operative interventions. Furthermore, potential complications associated with surgery, such as recurrence, cerebrospinal fluid leakage, hematoma, and infection, can be avoided by single nerve root block. It has diagnostic importance as well. It decreases the inflammation around the root, because steroids do have, apart from anti-inflammatory effect, it works as anesthetic as well. But we must be clear on the level and the site, and that our features in the patient, the clinical features, must be in the concordance with radiological findings as well before we proceed for the procedure. And the 6 basic steps are: we must identify the area, appropriate patient positioning, and use fluoroscopy for the targeted area, needle injection under the guidance of fluoroscope, and there has to be the confirmation. We must confirm exactly in the triangle, where the safe triangle, where we want to position the needle before we finally go and inject the drug. So certain anatomical structures we must delineate before we proceed. In the AP view, we have to locate the spinous process, transverse process, pedicle, and interlaminar space. So this is typically what we learn from our textbook, which is Scottish Terrier sign. We compare with this typical Scottish dog, and where you can see locate that. As from, you can see from the picture, eye, neck, front leg, ear, nose, tail, body, hind leg. So that is for descriptive purpose, but we can do right away. If we don't want to go into these intricacies, we can directly see the AP and lateral view, and we can locate the safe triangle, which is actually very easy to do so. And we need to be a bit meticulous and accurate, and not to hurry. And this is a 5-minute thing. You can do it perfectly well. So tip of the superior articular process, and the 30-degree is approximately inclination that you want to have the image inspired to go to, if you want to follow this typical Stocky Terrier sign. And tip of the superior articular process should bisect superior pedicle. Tip of the superior articular process should be in the upper 1/3 of the disc space, and near 90-degree angle between superior articular process and superior aspect of the body. So this is how it is. When we see in the 30-degree oblique view, this is the picture we generate. And in AP and lateral view, this is the safe triangle where you have to place your needle before injecting drug. Like this is the case of disc herniation, and there is bilateral recess and foraminal stenosis. Left is more than right. So there are some, before you start this procedure, the patient should avoid having anything, because it's a kind of a spinal procedure only, because in case the drug or anesthetic leaks into canal and some complication which expected may happen, to prevent so, we need to obviously, and there's consent and blood pressure has to be monitoring, and needle can be 22, 24 or 26 as per, and 3 ml of xylocaine plus 1 ml of bupivacaine and 2 ml steroid. Bupivacaine is something which can be avoided because it has got serious complications associated with if it gets intravascular. So xylocaine alone can be sufficient, and mixed with 2 ml of steroid, triamcinolone or methylprednisolone. So you mark the structures, the spine process, and you see in the AP and lateral view, locate it, and take the oblique view directly, and this is where exactly you need to place your needle. This is the stockit areas, and once we inject the radio opaque dye to locate that when you are going to finally push the drug, it is appropriately placed. So this is essencing. This is how it should be. And this is the Cambian triangle. And the borders are pedicle and ejecting nerve root and the lateral border of vertebra. And this is the demo, just one more minute. Here's Abhishek doing it. I think there is sound is a bit less. Where is it? End it? Thank you, Abhishek, for giving this presentation. I think he was not well and he has. So thank you very much. Thank you.
Dr. Mahesh, big brother, and very good friend indeed. Dr. Mahesh, I request Dr. Upender sir, President BOA, to felicitate Dr. Mahesh and present a memento. Next is a talk by Dr. Mahesh Prasad sir. He will be talking on cervical discectomy and fusion using stand-alone case or plating.
Hello. Thank you for inviting me as a speaker here. And I would like to say Spine Society of Bihar is a new society which was working on I think 2019 onwards. And now the new officials have been selected, myself being a secretary of Spine Society of Bihar and all the team of Spine Society here. And I convey my message to all the spine interested people or our postgraduate students who are doing so well in the medical colleges. So I invite all the spine workshop and everything in Patna and everywhere. Most likely 9th of November, I would like to arrange a seminar on such a spine topic. So you all are invited in Patna. And today I would like to my topic ACDF technique. This is the basic technique, most rewarding technique in the cervical spine surgery. There are two types of surgery in cervical spine. One is the anterior spine surgery and one is the posterior spine surgery. So I personally feel that the anterior spinal surgery is the most commonly done today. And of course, a posterior spinal surgery, of course, the most demanding nowadays. So, ACDF is the most widely accepted procedure for both single and multi-level cervical disc disease. Multiple modification of this technique is available. Surgeons have access to different type of plate, screw, cages, and also newer advancements such as standalone cage and MIS technique as well. ACDF is an advanced technique was popularized by Clover, Smith and Robinson, and it has been found that excellent long-term clinical outcome. So this is the basic anatomy of the neck. You know, this is the muscle around the neck. This is the plane where we reach anteriorly in between the medial aspect of the trachea, esophagus, and laterally the carotid sheath. So you go directly on the anterior cervical spine. This is the basic cross-sectional anatomical structure. This is the disc or a posterior element. This is the basic anatomy of cervical spine. I am not going to detail. I would like to focus on the basic step how to do this ACDF. This is the one case of 34-year male, C5, C6 injury of herniated disc, and level power is grade 2 and lower limb grade 0. So this is the MRI picture. You just see L5, 5, 6 level. This is the disc just posterior to the vertebral body and just compresses the cord and contusion as well. So my operative technique is to find out on this way. This is the positioning operative picture. This is the find out the exact location by a fluoroscopy. And what is the main structure? You just dissection out. This is the basic instrumentation, just basic, not a very hefty type of instrument, just a simple one you can do inch every setup. So my instrumentation on this, simply carinations, hook, retractor, Langenbach, all these. This is the position of my patient on the operation table, just extension of the neck, put a bolster on the back of the chest so that your neck will be totally extended. This is the, after draping my patient on the neck, this is the cranial side, this is the distal, put a xylocaine locally to reduce the bleeding side. This is the incision, just put a transverse incision on the crease of the neck on the side of the patient, just exposing the area to be operated or dissected the disc. This is localization of the exact site, confirmation by fluoroscopy. You just put a needle on the space and find out the exact location. This is the process of removal of the disc by disc forceps. You just clean it out all the way, all your disc, prepare the disc space, all clear, end plate preparation for grafting and cage. This is the whole area you extruded all around. Make a space for your placement of a cage. Just measuring the size. How to measure this? You just put the cage sizer and access which size of cage you are using. This is the cage with a graft material put inside. Inserting the cage. After this, you just assess the size of plate, which one is better to fix both upper and lower vertebrae. This is the fixation of plate, and after fixation, this is the size of your incision. This is the post-operative picture of a case. This is the final closure. So these are the steps you can follow these. These are a common indication you all know, nothing new about that. These are the complications. Most important complication I feel that the post-operative dysphagia, either a hematoma or sometime a worsening myelopathy, sometime recurrent laryngeal nerve palsy, wound infection, etc. But these complications are not very common. This is our second case, Chotu 30-year degenerative disc. This is the C5-6 disc with a weakness in the both lower limb. This I can find here you use a standalone cage after removal of the disc, and this is the post-operative picture of these cases. This is the operative picture of a standalone cage which is inserted inside the C5-C6 disc. Another case, this is the old case which is after 2 to 3 months reporting. This is the unstable disc. And radiculopathy, power is not lost here. We have to plan ACDF, this area. And after surgery, this is the patient. This is the outcome, very wonderful, optimistic. Patient is very happy. And one of my paper in a research during the PhD, what are the operative benefit of a standalone cage over anterior cervical plating? So I can say that in some cases we can use a standalone cage, and some cases we are using a plate. But there is a definite operative benefit of a standalone cage, like reduced blood loss, improved cervical lordosis angle, reduced postoperative dysphagia, and reduced adjacent segment degeneration, and shorter operative time. Thank you. Thank you very much.
Thank you so much, sir, for this insightful talk. Now I request Dr. Upendra Prasad, sir, President Bihar Orthopedics Association, to felicitate Dr. Mahesh Prasad, sir. There are 3 more video sessions coming up, all 3 by Dr. Ayush Sharma, Dr. S.K. Srivastava sir, and Dr. Guru Raj sir. All 3 are very interesting topics. Dr. Ayush Sharma sir will be right now talking about endoscopy in lumbar spine, how and why. This is a video demonstration, video presentation by him. So as we all know that Dr. Ayush Sharma is a very famous minimal invasive spine surgeon. He mostly deals with tubular discectomy and decompression. Today he will be demonstrating on endoscopy in lumbar spine, how and why.
Okay. So, you know, there are a lot of confusion on endoscopy. So basically what I am talking about now is a full endoscopy. So endoscopy, if you look, can be full endoscopy, UB, dextran, do a lot of things. But as such, the full endoscopy is the one which has the minimum footprint. So let's see, this is my disclosure. I was an open surgeon for 7 years, a tubular surgeon for another 5 years, and then I met this beautiful girl, which is the endoscopic spine surgery, and I decided to convert myself to endoscopy. Why endoscopy? If you want to look at spine up close and personal, nothing beats endoscopy, because your visualization tip is just close to the spine. If you are operating from naked eye, you are looking at spine from the height you are operating. Even if you use a microscope, all your magnification is up. But if you want to visualize a spine in a close way, I think this is the most beautiful thing. So full endoscopy, I will show you a series of video, but let me make you understand what it is all about. So basically there are 2 approaches in full endoscopy. First is the interlaminar approach. Interlaminar approach is nothing but what you do in your day-to-day posterior approach. So basically you utilize the interlaminar window to do the surgery. It's a familiar approach. If you're doing spine surgery, you understand how the posterior anatomy is. It is a versatile approach. Anything which can be done by open or tubes can be done by interlaminar surgery. Plus, please understand the interlaminar windows changes as you go from down to up. So patient selection becomes very, very easy. So look at this case. This is a small L4-5 5S1 extruded disc. For a case like this, endoscopy is the best thing. All you need to do is to go there, you visualize the root, you retract the root, and you take your disc out. And it is a 20-25 minute surgery at the best. And that is all you have to do. And at the end of the surgery, once you have this disc fragment comes out, and then you just ensure that the nerve, which is completely free, and this is what you can see is the disc fragment has come out, and you will see the nerve root, which is free, and that is the aim of your surgery. So something like this is one of the easiest thing you can do, and this is a complete, free nerve at the end of the surgery. Now look at something like this. It's a huge extruded disc coming from 5S1. It is filling the complete canal. Can you tackle something like this endoscopically? Of course you can. This patient comes with a foot drop, but this is what we did. And look at the angles you can go, even with a open surgery. Getting the angles is a challenge, but with endoscopy, just using the angle, you can do everything. And look at, this is the decompression at the end of the surgery. This shows both the root. Not only you can look at the S1 root, but even you look at the L5 root, because in this case, the disc was migrating up and it was even going up to the L5 root. So just the change in the angle and the visualization, you can see everything. So whatever you can do with open, I don't think endoscopy you cannot do. It's all about technique, learning the technique, the tips and tricks, and doing the job done. And this much is the disc fragment which was removed in this case. And look at this post-operative MRI. If you have ever doubted that it cannot be done endoscopy, the MRI is in front of you. Now, if you want to add a decompression, it is not at all a problem. You can add a decompression just like you do for any open or tubular case. But this is a different world. That the other aspect of endoscopy is a transfemoral surgery. Here, you have a completely different perspective. You go to a transfemoral approach. If you look at it, it is completely different from what you have done from posterior. So you are going through the foramen, and for some cases, like extraforaminal disc, which you can see here, this case comes with a list and radiculopathy, and you can see there is an extraforaminal disc. Now these cases are very, very difficult to tackle, whether you do tubes or you do open. But if you are doing endoscopically, it is very, very small job. All you need to do is put an endoscope. Once you go, you will already be there, and you remove the disc, and end of the day, you see this red angry root, and that is all you needed to decompress. So instead of a big surgery, it becomes a very, very small surgery. And normally, these patients are very, very happy. Now, like something like this, a high up L2-3 central disc. Again, if you are doing open or tubes, these are challenging cases. But if you go endoscopically, transfemoral, you just are there. All you need to do is reach there, remove that disc fragment, and that is the end of the surgery. So you see this, you reach there, you see the disc fragment comes out, and just by changing the approach, instead of doing laminectomy, removing the bone, you have been able to do what you want to do was to remove the disc, and it is as beautiful as it can get, and that is the end of the surgery. And this is the post-op MRI. You can see the complete disc has been removed. Now, even for discitis and case like this, it is a beautiful surgery. And see how beautifully you can not only look at the spine, look at the amount of pus simply pouring out just by you putting a scope. And this happens for next 10 minutes in this case. And this patient was unfit for general, so we did it in local. He's talking and everything. He's an old patient with CKD, and that's why he got infection. And it came out to be E. coli in this case. Now, this is a calcified disc at D12L1. Again, more complicated case, but if you have endoscopy, it is not a problem. You can use these drills, burr out the complete calcified disc. As you can see here, all you need to do is burr the complete disc out. Once you have burr out that calcified disc, then you see the nerve root and the disc. You remove the disc material, and this is at the end of the surgery. You can see a free floating dura. Just by changing in approach, you can do some complicated cases and can get away with it. Everything in your life, including endoscopy, does have its learning curve. So please understand, as Dr. Srivastava sir was telling, please understand the anatomy. Please go through the basic principles of open surgery. Maybe if you can do tubular, and then venture into endoscopy, because there is a learning curve, and the learning curve for endoscopy compared to open surgery is quite steep. If you change the way you look at things, the things you look at changes. So it is another way to look at spine, and sometimes it could be a very, very easy surgery by just changing the approach you do. If there is a will, there is a way, and this is my setup. We started 6-7 years back, and now we have everything in the world to do endoscopic surgery. And if you can do a surgery with less than 1 centimeter incision and give a similar result like open surgery, why not to choose it? All the limits which you have is in your mind. And if you change your mindset, I think you will be able to do excellent things in endoscopy surgery. So that is about endoscopy.
Thank you, sir. Our next talk again is on tubular decompression for spinal stenosis, which is fairly very common procedure. So Dr. Ayush Sharma will be talking on that.
So again, tubular is, when it comes to decompression, decompressing the spine, I prefer tubular because I can do it fast. I do endoscopic decompression as well, but I am faster with tubular. It's easy in my hand, so that's what I do. So even before you start to do a surgery, please understand the target. If you have a wrong indication, everything changes. This L4, 5 both looks like a similar case, but look carefully. If you look at it, there is a facetal fullness and the other case is completely different. It is not a case for tubular decompression. Maybe there is instability. So even if you are a tubular surgeon, please understand the indication, the principles, and the anatomy never changes. It is the same whether you are doing open endoscopy or tubes. So this is, for tubular surgery, you need to have a tubular system. You need to have some sort of magnification, either a microscope or a loop. You need to have MIA accessories. These are some things. They are, implant sensitive or instrument sensitive. You need to have a good C-arm. A simple good C-arm is important because your landmarks you cannot see, you cannot palpate. It is all based on the images which you see in C-arm. Tubular retractors are very versatile. And not only you can do the one side, but you can do contralateral as well. So this, because it's a video presentation, this is the tubular video. You can see this is a stenosis at L4, 5 level. Most important is the docking. You need to dock at the spinolaminar junction, and this is how the docking looks like. If you want to understand more about it, please go to the AO website. You will get a complete flowchart how to do it. And then this is the cranial, this is the caudal, this is the medial. You get some amount of muscle which you need to, burr out. And once that is there, the anatomy is similar to your open surgery. Then what you do is you use a high-speed burr, and this is what you're looking at. You're looking at part of the lamina and part of the ligamentum flavum here. And then you use this high-speed burr, and you just take out the lamina out. So, this is the ipsilateral laminectomy. You take the lamina out. Once you have taken the lamina out, you expose the ligamentum flavum. Once you have done that, you don't go into the dural area, but you do contralateral first. Means you tilt the tube and remove the opposite side of it, because the ligamentum flavum will protect the neural structure so that you don't damage them while you're doing the surgery. So what I'm doing here is taking out the contralateral, opposite side out by tilting the tube. Once you have taken that out, then this is, again, you can see the tube has been tilted, and then what you can see is the yellow ligamentum flavum. Complete over the top decompression has been done. The bony work has been done. I have preserved the lamina till at this stage, and once your all bony work has done, that is the time you start removing the ligamentum flavum. And removing the ligamentum flavum is just like you remove in open cases or endoscopy cases. Again, the principle of decompression is the same. This is some contralateral facets we are removing. Even if you have a hypertrophic facet on one side or other side, that is not a problem. You can do it. And once you have done all the ligamentous work, you start slowly removing the flavum. And this is the flavum being removed. And it is just like you take a ronger and you make sure that everything is just removed. And it can be done fast. It is this normally a tubular decompression is 20-25 minute surgery in a simple case. And this is what you can see. And at the end of the decompression, you can see the good dura, which is completely free. And if you feel that contralateral is a problem, just look at this case. And again, just to show you all these steps, not only you look at your side, but the same steps were done here, but you can easily look at the contralateral side. And so this is like, this was for a decompression discectomy. And I just wanted to show you that this was the ipsilateral side, but how much you can do. So this, you can see, we have done the ipsilateral side, we have done the decompression, we have done exactly what we did for the previous case. But you can also look at the contralateral side, the contralateral root, the angle and the visualization. You see what I'm doing is tilting the tubes. The angle and the visualization allows you to see your side, the root on your side, the flavum you of course remove. And now what we are trying to do is take out the facet on and the lamina on the other side. And once you have done that, see how easily the dura can be retracted. And see, you can see the disc on the other side as well. And even if you have to remove it, it is not a problem. It's just the technique which allows you to do so much. So it is as good as doing, the open surgery, or as good as doing any other technique. It's just the technique and the visualization. But the advantage is you're not removing a lot of muscle, you're not sacrificing everything. So basically that is what I wanted to show you with the second video. And this case, this is the end of the decompression. You have a dura, you have seen the root on one side, you have just seen the root on the other side, and you have complete disc work. And this is the beauty of the surgery. See, this is a post-operative MRI showing a good decompression at the end of the surgery. And look at the muscles at the end of the surgery. If you're doing open surgery, these all are gone, and these muscles are for a reason. Whatever the God has given is for a reason. They do a function, and the beauty of these tubular or MIS approaches, you can really preserve the muscle. So if you look at it, the tubular surgery are one versatile approach. You can do from discectomy to, you can do a decompression. If you want to do a TILIF, everything is possible. And then this is my message to you. A fast surgeon is one whose patient get discharged without complication and are able to get back to their job at the earliest. Time has come to measure from onset of illness to return to work, and not from skin to skin. It is not about doing the surgery fast. It is about doing a good surgery which allows patients to recover fast and go back to his life. And that is what this tubular and minimally invasive surgery brings to the table. Thank you. Thank you so much.
Fantastic talk, sir. Fantastic talk, sir, and very elegantly shown the videos. Your last message was also very loud and clear. There is a small announcement by Dr. Gurujaz, sir. Before that, I would like to invite Dr. S.K. Srivastava, sir, on the stage. He will be showing us a video on pedicle screw insertion in thoracolumbar spine, a very interesting topic for the PG students.
Okay, so the certificate for this today's course will be issued by AO Spine, and people who have registered only will get those certificates. So there is a link with you all, and whoever has not registered, please do register so that you can get your certificates on the mail. Thank you.
So very good evening. Again, this I am going to show you how to pass pedicular screw. Now, this is going to be an open one, and each step I will be explaining. Now, when you do all these open surgery, you visualize, you palpate, and you feel the whole thing nicely, so that when you go for endoscopic procedure or minimal invasive, you have that imprint. So, these two procedures, one was shown by Dr. Mahesh, when you put the steroid in that area, or when you do pedicular biopsy. These are the procedures you should do first, to learn that thing, and then you go for surgical procedure. It will be easier way to ascend. So these root blocks, facet blocks, and taking the pedicular biopsy on your own. Don't send to the a radiologist. Do on your own the pedicular biopsy. The material you get from these pedicular biopsy done by a surgeon is much better. And you take out the whole chunk of the tissue from there. So to start all these endoscopic procedures, this way is very important. Now I am going to tell about this. Now this I am on a skeletal model. Now this is for the thoracic. So there is a rib, the midline structure, spinous process are downward, and this is, so even with the closed eye, if you have with probe, you can know what you are touching. So basically when you wish to pass the pedicular screw in the thoracic area, from this lamina there is a ascent of this transverse process, and the upper 1/3 of this ascent is actually the entry for the pedicular screw. See the point of that pen which I am putting. So if you divide this transverse process in 3 parts, upper 1/3, middle 1/3, and lower 1/3, The upper 1/3 is the site. So where it is descending, that is the entry point for pedicular screw for thoracic spine here, like this. So this is for thoracic spine. When now you go to lumbar spine, now this is L3 vertebra, you know. So you palpate the transverse process. This is the mammillary process. This is the superior articular process, and in the center line of this transverse process, you go towards medial side, and at the junction of this, the superior articular process, that is the entry for the pedicular screw for the lumbar spine, and this is the direction. You converge it and go slightly downward as per. So this is a case of L4-5 listhesis, you can see, and there was neurological deficit in this patient. And here I will be showing you how to pass pediculars with following the orthopedic principles. You know, just putting the screw doesn't matter. When you are inserted the implant, it should not come out, it should not fail. So I usually follow. So now this is the infiltration is being given. Expose this area. Why video is not running? It should move, no? Sorry. I go ahead again. Yeah. So this is pars interarticularis. This is pars inter. This is the superior articular process. That is the inferior articular process of the proximal vertebra, and this is the transverse process. So that is the site for the entry. So you palpate this whole area, and in the center of it, that is the point of insertion for pedicular screw. So this is the initial, mark which you are putting, that Lanke, and you put with the, you pierce that area, outer cortex, and palpate it, you probe. And you palpate it nicely. You should be able to palpate the distal part, the proximal part of the pedicle, then distal part of the pedicle, medial and lateral. Okay, and the feel itself tells you that you are in the pedicle. Okay, so in the proper direction, you pass the K wires. Every level you need not take the C-arm suit, it is not required. And you take AP and lateral, and here this AP view, it should not go or cross the midline, it means you have perforated. So AP lateral, so I have put the K wire both the side. Now this is the side I am going to insert the pedicular screw, and you will find that I spend time to tap each, 3.5, 4.5, 5.5. Now 3.5 you can, or 4.5 you can go till distal, but rest of the thing you should not tap whole of the track, just initiation, so that you don't struggle, because many of our Indian patients now it is porotic, and while inserting the screw you should not crack the pedicle, then the hole goes. So this is important, so that I have just make an track with the smaller diameter, and then just tap the pedicle for the larger diameter. So if you wish to pass 6.5 screw, you tap 4.5 till the distal end, then 5.5 and 6.5, only the initial one you tap. You don't tap the whole track. So you will find that the hold of the screw is very good. In fact, if you pull it, you can pull the spinal column. It is so tight. So sequentially you increase this. Now I am not rotating the full thing. We usually use the Indian systems. So there you will find that when you have put the screw, this screwdriver, and after tightening, the screw is not straight, it is slightly tilted. And if you start pushing in a whole round, 180 degree, then your track becomes abnormal. So this we have learned with the need. Never it used to be straight. So always when you rotate, don't rotate more than 45 to 90 degree. Then what happens, that abnormal curvature, it is taken by your handle of your tap. Okay, so just rotate 90 degree, this will not cause problem. Now in this case I had this listhesis, so I used reduction screw in L4. So when you are going to use the reduction screw, the head of the reduction is longer. So here I first passed L3, L5 and now reduction screw at 4. So it will not come because that screw, so mainly the S1 screw, when you pass it is quite oblique, so it will come in your way. And in osteoporotic bone, use your fingers. It goes nice. Don't press with your palm, and suddenly it will go. Whole thing will go in. So 6.5. Just initial few thread you go in, and then take it out. Yeah. Now this is reduction screw. You can see the head part. There is a longer flange. Now it is important to contour the rod. So it should not be premature reduction, or it should not remain unreduced. So the trick is in the contouring the rod. And this all we have learned with the high grade listhesis. So if you find that prematurely it has that screw head has reached there with the rod, then you have to under contour, and if you have over reduced it, you give lordosis. That is the trick. And we had a formula in high grade listhesis. You can measure in fact with the curved K wire, and we used to apply X and Y distance, and we used to measure, so you get a good reduction, because good reduction is important. And now here the that listhesis is reduced, and we have and cage. Even the one side cage, you can shift the cage to midline with a technique. So earlier we used to use rectangular bone graft for all this pliff thing. So you just start pushing it medially with the different sizes of the puka from lateral to medial. Any question?
Okay, thank you so much, sir. Any questions from PGs? Okay, our last and final talk, thank you so much, sir, for having this talk. Our last and final talk is on most common procedure which we do day to day, which is T-lift. Sir will be showing us video on that.
Thank you. So let's have some winning runs scored. Before I go to video, I'll just show you a brief slides of the steps so that you can understand the video better. So we know that these different approaches are there. So one which we are going to do is this, that is transforaminal lumbar interbody fusion. Anything which is anterior to psoas is O-leaf and A-leaf. Through the psoas is X-leaf or L-leaf, and when what you do it from posteriorly, that is posterolateral fusion. It's used and most versatile procedure. Wherever fusion is necessary, you can do this procedure, even including where sometimes your end plates are involved, you can do interbody fusions. So positioning is very important whenever we do fusion procedures, because in lumbar lordosis, maintaining the lumbar lordosis, not creating the flat back is very, very important. So whenever you position, you have to position with the hips in extension so that lumbar lordosis doesn't get obliterated. Typical OT setup looks like this, and approach is standard. You erase your muscles subperiostally from inferior to superior till the entry of pedicle screws, and you put your pedicle screws. Then basically you do 3 cuts, one onto the lamina, that is a vertical cut, one onto the pars, so that you take out this inferior articular process, and one onto the superior, 1/3 of the superior articular process of the inferior vertebra, so that you access the disc properly. So that is the area of interest. Inferior lamina is removed. You can see that superior lamina is exposed, and then you take out the superior 1/3 of the superior lamina, and then you see this triangle with the exiting nerve root with the thecal sac and the superior border of the pedicle. So you work through this triangle. You can use various instruments for this. You can use osteotomes, you can use a high speed burr, or you can use a bone scalpel or a piezoelectric scalpel. So the most important thing is this leash of blood vessels. This is very, very important, because these blood vessels can lead a lot and then increase your blood loss. And then a fusion procedure, preparing end plate is very, very important. You have to be very patient. Try to prepare your end plates very well, and then do a good bone grafting, because if you don't put a bone graft, it doesn't fuse, and then you will have problems. So this is just a small steps how it actually looks. So then we will go to video. So MIS TLIF, the same thing is done through the tube. You see the same structures through the tube, and the steps are same. This video is not working. I'll just go back and then play a video from here. Okay. So that's your head end, that's a foot end operating from the left side. So the pedicle screws are already put. We are going to do a T-lift from the left side. So right side I have already stabilized. You can, when you have a smaller disc spaces, you can stabilize at the end of the procedure after you have done your T-lift, so that you jack up the disc. That is the inferior edge of lamina. You just erase your ligamentum flavum from inferior surface of the lamina, and then you start doing your those 2 cuts. So I am using a high speed burr here. So that's the vertical cut onto the lamina from inferior to superior. So here you have to be very, very careful with how medially you have to go, how laterally you have to stay. If you are too lateral, you will not be able to see the thecal sac, lateral portion of the thecal sac. If you are too medial, then you will end up into the opposite side. So that's the horizontal cut onto the pars, and once you do that, you release the capsule, identify the facet joint. So regarding the facet capsule, you have to erase only capsule of the inferior side with the play of the joint which you are intent to fuse. The superior pedicle screw where the facet capsule, that capsule has to be left intact. So with the burr, you always, it's a feel factor. You just feel that you have, there is a giveaway sensation which indicates that you have already cut the far cortex. So you can see my burr just dips in and then just comes out. You can see that ligamentum flavum is seen there, yellow thing, and then slowly and gradually you lift up this inferior facet. Sometimes it might be stuck to the dura, or sometimes the flavum is stuck to the facet. If you pull it just like that, then you can have dural tears. So just release it more slowly and then rotate it and take it out. So now you can see the superior facet with the capsule. So the superior facet, again you can take it out down from the using burr, or you can do with the Kerrison rongers. Your Kerrison ronger has to go flush to the superior superior border of the pedicle, superior wall of the pedicle. So till there if you go, you can access your disc properly. And then you are doing a flavectomy. So slowly tease out the flavum, see if there are any adhesions, and then you can use your Kerrison rongers and then do a flavectomy. This video is old. Now I take out this flavum en bloc by doing a small cut here and small cut inferiorly. You just take out the one side flavum in toto. So once you have done that, you will see now that your thecal sac is here, and that's the exiting route. This coagulation of the epidural blood vessels is very, very important. You have some particular points. One is at the shoulder of the traversing route. One is at the axilla of the exiting route, and just below the thecal sac. These are the main three areas where the epidural vessels are at high concentration and they can bleed from there. So before putting your knife onto the disc, you coagulate these epidural vessels properly so that you don't have any bloody field, and then if they start bleeding, it's very difficult to coagulate and control the bleeding. So once you coagulate, then your next step is to just erase these coagulated epidural vessels from the annulus. That's the annulus if you see there. So that is the annulus. So you do a box cut so that you can easily see the end plates properly, and then introduce your shavers or sizers. So that's the box cut being done. A lot of people do it in a different way. People just take a cut and then introduce the shaver and start doing, or in initial few days it's better to always define the extent of the discs superior inferiorly so that you don't injure the end plates. So you start taking out the disc and then you start preparing the end plates by using different equipments which we will show. So here you have to be very careful how much inside you have to go. Don't go to anterior to the ALL and cause major vessel injuries. So there is a disc. If at all you have a disc prolapse in these cases, it's better always wise to take out the prolapse part of the disc first and then start doing end plate preparations. So those are the shavers. So be very, very gentle and careful, especially in osteoporotic bones, because if you shave off the bony end plate, then your cage will subside, patients will have severe post-operative pain, and your screws will fail. So be very gentle. With the gentle rocking movements, you just shave off and then take the pedicle. This is for the superior end plate. You can see those angled curettes. So that's for the inferior end plate. You have different angled curettes for that. This is a box curette. These are all used for end plate preparation. You have to be very, very patient when you do this step, because end plate preparation is key for the fusion. So this is a different kind of box curette. This is just for showing. I have used all those curettes there. Now you size your cage. And then give a good intradiscal wash. So that's end plate preparation still going on, and then another 2 minutes. So you give a good wash to wash off whatever remaining residual disc left there. So those are the sizers. Size disc properly, which is snugly fitting. Tend to avoid any compression distraction on the screws, because screws can get loose. So try to get a snugly fitting cage. So with serial sizers, see which is snugly fitting, and pack the disc space with good amount of bone graft, otherwise you will not achieve fusion. And then that's the cage. Be very careful when you introduce cage to protect the exiting and traversing nerve roots. And then cage should at least cross the posterior 1/3 and be it in the middle 1/3 or anterior 1/3 portion. So just check for, once you have placed your cage, just check for any residual disc or any residual bone graft which was packed into the cage. Just check for that, whether nerve root is free, whether any residual fragments left. So that ends the surgery. Thank you.
Thank you so much, Guru Raj sir. With this, we conclude the
Thank
session.
you.
And now I hand over the mic to Dr. Gyan, who will be doing the quiz session.
Thank you, Abhishek. Thanks a lot. So we have 9 people. We have selected 9 participants. And then we'll have second round of the quiz. The first 9 persons who have scored. First one is Shashank Shekhar from DMCH. Second is Dr. Jolly Kumari from DMCH. Dr. Abhishek from IGIMS. Dr. Suvam Vats from DMCH. Please come on the stage. Dr. Vivek Kumar from JNMCH. Please come on the stage. Come. Please come on the stage. Jolly Kumari, Vivek Kumar, Shashank Shekhar. Dr. Akbar from DMCH. Dr. Akriti from IGIMS. Dr. Divyansu from PMCH. And Dr. Kaushik from DMCH. Dr. Kaushik from DMCH, Dr. Divyansu from PMCH, and Dr. Akriti from IGIMS. Dr. Akbar from DMCH. I think we just have 4 people, rest 5 people if you can hear me, or if you can call your friends. यहाँ पे कौन नहीं है? नहीं नहीं 3 people, na? Again, I call away the names. If anyone of you are here, please come on the stage. Dr. Shashank Shekhar, DMCH. Dr. Jolly Kumari, DMCH. Dr. Abhishek, IGIMS. Dr. Subham Bats, DMCH, Dr. Vivek Kumar, JNMCH, Dr. Akbar, DMCH, Dr. Akriti, IGIMS, Dr. Divyansu, PMCH, and Dr. Kaushik, DMCH. So we have 4 people. 5, we have 5. Fine, we'll go ahead with 5 people. Sir, can we? Your good name? Akbar. You are from DMCH? PMCH. Okay. Fine. So we have 6 people. We'll make 3 groups. We'll wait if anybody has to come. Priyanka is right. We'll wait. So what is our plan? We'll make 3 groups and we'll have a rapid fire session. And whichever team wins, that team will be given the fellowship. First, second, third. And the name in that will be selected on lottery basis. है ना? हाँ. So just we'll make 2 groups. That would be good. A and B. And whichever group wins, those 3 participants of that group will get the fellowship. Okay? on her, and that selection, of course, we will have a rapid fire round that will have 10 questions. You have to answer as many questions as you can in 3 minutes. 3 minutes, 10 questions. The group which scores the maximum, that group wins, and winners will be getting fellowship. As you know, the fellowship award is at three places affiliated to Mumbai. AO Spine Center in Mumbai, in Delhi, and Cicero Hospital in Patna, and Dr. SN Saraf Hospital will be providing travel tickets, your travel tickets for that. Right? So should we go ahead with it? You are ready for that? Great. It would be better if you guys can sit here on the front, two teams. But just wait. How will? Just wait. Group A and Group B, na? Come here. We'll make. इसमें से C हटाना पड़ेगा ना? C हटा दीजिए.
किसी में से निकाल दीजिए ना, जो नहीं होगा उनको हटा दीजिए.
इसमें से पता कैसे चलेगा ना?
आप निकाल भी चाहिए, 3 लोगों को निकलवाइए, 3 जो निकलेगा वो नहीं होगा वो हटा
जाएगा, है ना? तो आप लोग सर से निकलवा. Sir, please come. We have to make the group, so we'll take the lottery. I request Dr. SN Saraf to please take out one name out of it. This is for Group A. The name is Dr. Akriti IGIMS. I think she is not there, sir. I'll take that, please. Sir, please take the another one. This is Dr. Subham Bats. You are here, you are in Group A, please come this side. Yeah. Dr. Akbar, you are in Group B, please stand that side. Yes. Dr. Abhishek IGIMS? No, he is not here. Dr. Kaushik? He is not here. Is it DMCH? Jolly. Dr. Jolly? Yes, this is yours. Please come here. Group A. This is Dr. Devyansu. You are in Group B. Please stand here. Please take your chair. Dr. Shashank Shekhar, you have to come this here. Here. So, sir, last one will go in Group 1. Yes. Dr. Vivek, please take that. Your slip. Thank you so much, sir. Thanks. So, now we'll start it. You can have your seat in front. One Group A can sit here, Group B can sit there. So, ready? Group A. Group B, you have mic. Hello. Again, I'm telling you the rules. There will be 10 questions. First 10 questions will be asked to you. And you have to answer maximum number of questions in 3 minutes. Once, if you don't know the answer, you can say pass, I'll go to another question. You got my point? Can we start? Timer? With the question, timer will start. Yes.
Sir,
Ready.
will there be no negative marking?
There is no negative marking for that. 10 questions, 10 marks. Yes. Multiple choice. There will be multiple choice questions. So, true or false? Displaced femoral neck fractures that anatomically reduced and fixed with cannulated screws can have osteonecrosis rate of 15%.
True.
Right. Name the abnormal radial or ulnar angulation of a finger. Oh, we'll ask an extra question in that. Don't worry. Chondroblastoma of proximal humerus is known as which bone tumor? Your time is running.
Pass.
This is Codman's tumor. Name the genetic factor for pauciarticular JRA. Yeah. Yes? You are right. DR 5 and 8, it's not 3. So, ulnar positive variance is associated with Kenbock's disease. Is it true or false?
False.
Right. This. Name the segmental nerve levels corresponds to sensational at the xiphoid process.
T4.
That is T7. Wrong answer. The inheritance pattern of polydactyly.
Autosomal dominant.
It is autosomal recessive. Wrong. Name the metabolic condition looking at the X-rays. Time is on. How much time is left? 59 seconds. Oh, sorry.
Multistotic fibrous dysplasia.
That is Paget's disease. Stress fracture is best diagnosed by
CT.
MRI. That is wrong answer. After whose name smack bandage is famous? This is very commonly what we use in our operation theatre these days. Used from long time, but we are more regularly. Tell me. Smarch is after whose name? Your answer? The time is up. Okay. So, have you calculated? Right. So, now we come to team B. That correct answer is John Friedrich August von Smack. After his name, Smack was used. Actually, he invented it. Yes. Ma'am, you were saying something?
I think out of 10, they have scored 2. And 1 has been given correct by him. Partially correct, I will say. It was actually DR 5 and 8, I think. Okay. So, we'll go with team B now.
Now, we'll go with team B. Team B, you are ready? Okay, for 3 minutes, you have 10 questions. There is no negative marking for every answer. Once you don't know the answer, you can pass. Your timer is going on here. So, we start with our first question. The stance phase occupies 40% of the gait cycle. Is it true or false?
False.
Right. Anterior cruciate ligament insufficiency is not a contraindication of unicompartmental knee arthroplasty.
True.
Answer is wrong. False. Bone cement acts as glue between impact and bone. True or false? Answer is false, wrong. 13-year-old fell with his bike. Identify the pathology.
Skiffy S. Sub.
If they pass it, I'll come to you for sure.
Fibrous dysplasia.
Pardon, come again. Can you speak?
Fibrous dysplasia.
No. Sorry, it's left hip CFE, right? What radiograph finding may indicate a medial collateral ligament injury?
Pass. Pass.
Can you answer it? Peligini? Okay. Yes, you are right. Then, during medial meniscus repair, which structure is most commonly injured?
Genicular artery. Genicular artery. Genicular artery.
Please speak louder.
Genicular artery.
Branches of saphenous nerve. Optimum position of flexion to hip to perform hip arthrodesis. Optimum position of flexion to perform hip arthrodesis.
15 degree.
Pardon?
15 degree.
30 to 40 degree is the right answer. You are wrong. The 8th question is necessary daily calcium and vitamin D intake in patients between 19 and 50 years of ages. This is very much needed for you.
1 gram.
1 gram? Your time is over. Is it? Yes. That's what I am coming. Elemental calcium is 1200 milligram and vitamin D is 200 international unit. One question I have to give you because unfortunately it got off. You can answer this question if you want. Which organism is most frequently found in patients with an infected humeral non-union? Propionibacterium acnes. So like we have finished it now we can count and we can say. Thank you so much all participants. We'll shortly come with the result.
First of all, very good collection of questions. I think orthopedics has been seeming tougher from them, I think. So team A has won with 2 marks and team B has scored only 1 marks. Okay, and Abhishek also has done very good because he has individually answered 2 of the questions as correct. So it's a tie. So you can do one thing that we can have this
we'll
lottery.
We'll let you know the thing. Anyway, team A, all 3 winner and Abhishek, shortly you will be informed. Yeah. So finally team A, you have got the fellowship and that's congratulations. And don't worry because you have answered 2 questions. So I'll come up with the for you I'll come up with something very shortly. You'll also be awarded, don't worry. But next time, please do come on time for the quiz. Don't worry. I'm thankful to Dr. S.N. Saraf sir for bringing AO to Darbhanga. It's like a dream come true. Getting AO in Darbhanga was really a big dream when 7 years back I came to this city, although I fluctuated a lot, but still, thank you so much sir for doing that. And thank you Priyanka for all your effort. I have your names now. Actually, I remember Jolly, Abhishek, Jolly, Shashank and Shubham. Please come on the stage. And Abhishek, right, you also come on the stage. Please give a big hand to all 4 people. Congratulations. Big day for you guys. You are going for your first fellowship. Sponsored by Dr. S.N. Saraf Hospital. you will be provided the air tickets to Delhi and Mumbai, to and fro, and for Patna you will be joining in Cicero Hospital. Please introduce yourself. I will be giving you the mic. You have the mic, right? Please introduce yourself.
Hello, Abhishek Kumar, third year PG from IGMS Patna.
My name is Shashank Sekhar. I'm a third year postgraduate resident at Darbhanga Medical College and Hospital.
I am Shubham Vats, a second year orthopedic resident in DMCH.
Dr. Jolly Kumari, second year PG resident, DMCH Darbhanga.
Congratulations, big day for you guys. The first fellowship. You'll always remember it. Okay, thank you. Thank you, everyone. We had a wonderful program. Now we can conclude it. Priyanka, anything else? Thank you. Thank you. Yes, Abhishek is here.
Now, finally, vote of thanks by Dr. Professor Sansaraf sir.
हाँ, दिल्ली, बॉम्बे और सिसरो वो तीन है वो चार है विनर. एक्चुअली 3 फेलोशिप और 4 विनर है. सिसरो यू कैन पुट इन सिसरो ना. तो और जो पहले 2 लोग होंगे यू कैन टेक आउट फ्रॉम द लॉट. अभी हम लोग कर लेंगे. आप लोग को लॉट दिया जाएगा. यू कैन सेलेक्ट व्हाटएवर कम्स अप. लास्ट 2 पीपल और हर जगह में देखोगे ना, मतलब देखने से ही समझ में आता है क्या क्या करना है.
हेलो. Respected faculty, distinguished guests and delegates, आज के इस ऐतिहासिक अवसर पर एओ स्पाइन हॉस्पिटल बेस्ड सेमिनार एवं स्पाइन वर्कशॉप के समापन पर मैं हृदय से आप सभी का धन्यवाद ज्ञापन करता हूं. सबसे पहले मैं अपने विशेष आभार व्यक्त करूंगा हमारे माननीय मुख्य अतिथि स्पाइन एसोसिएशन ऑफ इंडिया के अध्यक्ष प्रोफेसर डॉक्टर सुधीर कुमार श्रीवास्तव, इंडियन स्पाइन इंजरी सेंटर न्यू दिल्ली के हेड ऑफ डिपार्टमेंट डॉक्टर गुरुराज तथा आयुष जी का, जिन्होंने अपने अनुभव, ज्ञान और प्रेरणादायक विचार से आज के सेमिनार को काफ़ी सफल बनाया. आपकी उपस्थिति ने इस आयोजन को गौरवपूर्ण और यादगार बनाया है. मैं अपने ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर अभिषेक अनु तथा को ऑर्गेनाइजिंग सेक्रेटरी महेश कुमार एवं निशार अहमद को हार्दिक आभार व्यक्त करता हूँ, जिन्होंने अपने कठिन परिश्रम और समर्पण और बेहतर समन्वय से इस कार्यक्रम को सफलता की ऊंचाइयों तक पहुंचाया. साथ ही मैं सभी स्पाइन एवं ऑर्थोपेडिक सर्जन, पीजी स्टूडेंट एंड मेडिकल डेलीगेट्स का भी धन्यवाद करता हूं, जिन्होंने अपना मूल्यवान समय देकर इस कार्यक्रम को काफ़ी सफल बनाया. और आप सभी के सहयोग एवं उपस्थिति के लिए पुनः धन्यवाद. हम आशा करते हैं कि भविष्य में भी हम इसी तरह के शैक्षणिक एवं चिकित्सीय आयोजन एवं स्पाइन के सहयोग से करेंगे. थैंक यू टू यू ऑल.
Jolly will be going to Indian Spinal Injury Center, New Delhi. Shashank will be going to Mumbai. And Shubham and Abhishek will be joining in Cicero, Patna. Thank you. Big congratulations. You will बहुत टाइम लगा था और बहुत मेहनत करना.